Good afternoon and welcome to this bill hearing of the House Health Committee. I ask for your patience if we encounter any technical or streaming issues. This hearing is being streamed on the Maryland General Assembly YouTube channel. We do have a few virtual witnesses today, so just bear with us as we shift back and forth. Please note that food and beverages are not permitted in the gallery. Delegates may have drinks at their desks because some of these meetings can run quite long and we want to make sure everyone stays hydrated. Please make sure to turn off your phones or turn them to silent at this time. If a member is not present, please understand that they do have bill hearings in other committees and meetings as well, but they are staying informed on our proceedings. And please adhere to our committee rule of one question and one answer from the panel, not one question and one answer from each panelist. And please keep your questions shorter than the answers. Today we will be going in the following order. I've got House Bill 811, followed by 945, followed by 1068, 931, 917, 1112, 1093, and 637. Just for your awareness, sponsors are not time limited, but please keep it within reason so we don't have to revisit that rule. And all witnesses will have 2 minutes. Do I have Delegate Wallach here? There she is. All right. Delegate Wallach, if you want to come over and bring your panel, and you can begin your testimony when you're ready.
Good afternoon, Chair Bagnell, Vice Chair Cullison, and esteemed members of the Health Committee. For the record, I'm Delegate Sarah Wallach, here to present House Bill 811, the Village Multi-Generational Third Places Act. Thanks for the opportunity to testify in support of this bill. A village is a community-based, volunteer, and membership-driven organization that helps older adults age in place. This means safely, independently, and comfortably in their own homes and communities. The village model offers social engagement, personal enrichment, as well as transportation and personal care for older adults through peer-to-peer support between neighbors and the older adults they support. Not only does the village model help older individuals age in place in their own communities, but it also helps to address loneliness and foster social connection. Research from the National Institute on Aging has linked social isolation and loneliness to higher risks for a variety of physical and mental conditions, including high blood pressure, heart disease, obesity, a weakened immune system, anxiety, depression, and cognitive decline, to name just a few. People who find themselves unexpectedly alone due to the death of a spouse or a partner, separation from friends or family, retirement, loss of mobility, and lack of transportation are a particularly higher risk. A key tenet of building social connection with respect to villages is to have a place where planned or spontaneous or informal gatherings can occur. House Bill 811, the Village Multi-Generational Third Places Act, allows long-term and short-term rental or lease costs for third places to be eligible for aging in place grants. Multi-generational third places are defined as community spaces that support social connection, events, gatherings among individuals of different ages. Think of a place where neighbors can gather to play a game of card, watch a sporting event, or engage in any other activity without the logistical hassle of securing a place every time they want to get together. I'm fortunate to live in a neighborhood with a third place, and the connections that occur naturally across generations is something I believe is fundamental to our aging population across the state. I work closely with the Department of Aging on the development of this bill, and they are here today in support. There is no fiscal note because it simply allows for the use of aging-in-place funds to be, the villages, the third places, to be eligible for those funds. The DOA can handle this change with existing resources. I thank the committee for a consideration of House Bill 811 and urge a favorable report of this bill. Thank you.
Yeah. So good afternoon, Chair Bagnell, Vice Chair Collison, members of the Health Committee. My name's Liz Woodward. I'm the Assistant Secretary of Planning at the Maryland Department of Aging. I'm here today in support of House Bill 811, the Village Multi-Generational Third Places Act. The department thanks the sponsor for being a champion for villages. I wanted to share that as a reminder, in MDOA statute, senior villages are defined as local, member-driven nonprofit organizations that support community members who choose to age in place by fostering social connection through activities and events and coordinating volunteer help at home using a neighbor helping neighbor model. And they're also exempt from taxation under Section 501c3. The village model is one that we are really committed to at the Maryland Department of Aging. We want to see it grow in Maryland in the coming years in alignment with our Longevity Ready Maryland plan implementation. A couple of examples of our current work, the Department of Aging in partnership with the Washington Area Village Exchange and Maryland nonprofits provides technical assistance to Maryland villages. We fund villages through the Aging in Place grant, including 3 in this year's current cohort. And through the Miriam Kelty Aging and Senior Connection Hub and Spoke pilot program, we work really closely with the Montgomery County Village Consortium, which has developed a strategic plan, and they launched coordinated services last year. So as you heard from Delegate Wolick, this bill would simply make an important clarification in the department's Aging in Place statute, which is our primary funding mechanism for villages right now. This bill would confirm in statute that senior villages can use these funds more broadly for renting or leasing gathering spaces beyond one-time specific events. This really promotes more social connection, and that aligns extremely well with the department's Longevity Ready Maryland plan. So in partnership with you and Delegate Wolick, we really look forward to continuing to support the growth of villages in Maryland's communities, and I ask for a favorable report on HB 811. Thank you.
Good afternoon, Chair Bagnell and Vice Chair Collison and members of the Health Committee. My name is Betsy Carrier, and I serve on the Montgomery County Commission on Aging and was the founder of the Bradley Hills Village 10 years ago in Bethesda. I'm speaking on behalf of the Commission on Aging in strong support of House Bill 811, Aging in Place Programs, multi-generational third places. The Montgomery County Commission on Aging was established in 1974 and is authorized by the Older Americans Act to advise Montgomery County government on the needs of older adults. We believe HB 811 represents an important and timely evolution of the village model. As mentioned before, villages demonstrate that older adults thrive when they are socially connected, supported by neighbors, and able to remain active participants in their communities. However, many villages, particularly those serving more diverse and lower-income communities, face persistent barriers to accessing affordable, welcoming spaces where members can gather, build relationships, and connect across generations. The concept of multi-generational third places directly addresses this exchange by authorizing use of grant funding to support social connection through events and gathering in shared community spaces outside the home or workplace. Bill HB 811 strengthens villages and expands their reach. These spaces foster inclusion, reduce social isolation, and create meaningful opportunities for engagement across generations. The bill's flexibility to support operational and administrative costs, as well as short-term or long-term leases, will engage aging-in-place programs in senior villages to establish sustainable hubs for engagement. These hubs can serve as anchors for social connection. HB 811 aligns with the goal of making Maryland a longevity ready state by strengthening community infrastructure and supporting innovative models that reflect how people live and connect today. For these reasons, we support HB 811 and appreciate Delegate Wallach's leadership on this important issue and thank the committee for its continued commitment to policies that help older adults remain engaged and connected. Thank you. For these reasons, the County Commission on Aging urges a favorable report on HB 811.
Thank you, Madam Chair, Madam Vice Chair, and members of the committee. My name is Allison Siborowski, here today on behalf of Leading Age Maryland in strong support of House Bill 811. Leading Age Maryland is a community of nonprofit aging services providers, and as a statewide association, we are deeply committed to promoting health, well-being, and independence for older adults. Our mission is to ensure older adults have access to the services they need when they need them in the place they call home. We believe that grants to support social connection, as proposed in House Bill 811, are a cost-effective, evidence-based strategy to strengthen aging in place. As has been highlighted by other panelists, many villages face barriers in accessing affordable spaces where members can gather. This bill would add flexibility to the Aging in Place program, allowing villages to pursue short and long-term leases and rentals for these kinds of spaces. So I will yield the rest of my time and happy to answer questions, but in full support of this bill and urge a favorable report. Thank you.
And before I open it up for questions, Delegate Wallach, I had a Jim Sanders on your sponsor panel.
Yes, I'm not sure if she's here. Oh, there you are.
You can go ahead and yep, join the table and you can begin your testimony when you're ready.
So I'm Jim Sanders, representing WAVE, which is the Regional Association of Villages. We're testifying in support of the bill for a couple reasons. One is it provides capability for seniors in the community to be active. It also creates an option for people to age in place. We know the scientific research about the importance of isolation, so villages offer a way that local members can support aging in place, and that we're supportive of how villages help with cost-effective way to do housing. So I yield the rest of my time. I hope that you will have a positive report on this bill out of this committee. Thank you.
Thank you very much for your testimony. Now I will open it up to the members. Are there any questions for this panel? Delegate Warman, followed by Delegate Kaufman.
Thank you, Madam Chair, and thank you, Delegate, for bringing this bill. So I see that it requires a one-to-one match. So does an organization that is matched by a nonprofit, does an organization have to get funds to fund a specific project and then apply to the Department of Aging for grants? So it's like a two-pronged process, or?
Sure.
Thank you, Delegate, for that question. So the Aging in Place grant does require, it's a 50-50 funding source, so it requires one-to-one match. And that can be existing administrative costs, it can be volunteer time, and within the application process, we provide a calculation that's based on a national process that's put out on an annual basis. So it does require that match. Some organizations come with a project that has been funded elsewhere, some come with an extension of a project, and some come with volunteer match as their administration, and that's sort of looked at as part of the review process.
So could I have a follow-up, Madam Chair? Thank you. So an organization would, I'm just worried about just lower income organizations that have a hard time getting funds to begin with, being aware of that this program is happening. But I just want to make sure that they don't have to, it seems like the volunteer time requirement could be instead of some of the actual money, right?
That's correct.
Okay.
And the bill isn't changing the structure of the grant at all, in terms of, it's not speaking at all to the 50-50 match or the structure of how the grants are currently made. It is simply saying of the categories that are eligible for this grant, third place should also be eligible.
Okay.
So the structure doesn't change, but it adds an eligibility and says third
okay.
places can also get those funds.
Got it. Thank you. Thank you.
Delegate Kaufman, followed by Delegate Tavares.
Thank you, Madam Chair. Appreciate it. Thank you, Delegate Wallach, for bringing the bill. Great bill. I just have a question, and that is, from the people that, and whoever's best to answer, from the people who live in these villages, what to them, from what you've heard, is the most meaningful aspect of living in these villages? And you highlighted numerous examples of bad health outcomes and mental health outcomes if people live in villages. So do we have data that these villages reduce negative health and mental and physical health outcomes?
Thank you. I'd say that the most important aspect of living in a village is staying in your community, right? It's staying where you spent your life, where you raise your children, where you know your neighbors, and it's the villages sort of provide that social infrastructure so that you can stay in your home as you age. And I think that supersedes probably anything else that they offer, even though they do offer social connectivity events, you know, neighbors help neighbors, shovel your, when it snows, people come and help you maintain your property, they take you to a doctor's appointment. So all of that really helps fundamentally the ability to stay in community, and nothing beats that. In terms of specifically for villages?
Yes, follow up, Madam Chair, if I may. Yes, I asked, was there a lot of great anecdotal evidence, but was there any data on better mental or physical health outcomes for people living in the studies that show that people living in these villages have better mental and physical health outcomes?
Yeah, we can submit some.
Yeah, we can absolutely follow up on that. There's been an extensive effort on a national level to collect and sort of aggregate and look at the data in different ways. And I know the Montgomery County Village Consortium has also had a very active process as well, looking at what they take in and kind of moving from how we're counting to what really matters. Additionally, the Department of Aging has done an evaluation of our Aging in Place grant and can provide some data around that. And I absolutely agree with what Delegate Wallach is talking about.
Thanks, and if you could share it with the whole committee, not just me, that'd be great. Thank you, Madam Chair.
Yeah, absolutely.
Delegate Hill. Okay. I'm sorry, Delegate Tavares, followed by Delegate Hill.
Thank you, Madam Chair. I want to thank you for bringing this bill forward. Let me hear you better. It seems to me that villages are very effective within municipalities because there's a structure there to support them. But in unincorporated areas, they're very difficult to put together and build. And what we're talking about here seems just about $100,000, which for all the things there is just not enough to go around. But what are you open to including capacity building for some of these programs in unincorporated areas to give those, in those other jurisdictions, like shape for these to be able to be a little bit more successful? Because I just don't see it as being able to survive in other areas outside of municipalities.
So there are villages throughout the state, not just in incorporated municipalities. In fact, in my own district, they actually don't know if there's one within a municipality as such. It's a suburban area, and so there are villages throughout. There are villages in urban centers as well, in suburban areas. So they're widespread. But because of the nature to what you speak, Delegate, and thank you for your question, they look different, right? If it's a suburban village, may have a different setup than an urban village. I agree with you that the $100,000 grant for Aging in Place is very limited. I would love to be back here next year advocating for a bill increasing that amount substantially. This bill simply is saying that of the funds, a third place should also be eligible for disbursement. Yeah.
And just to clarify, Delegate Wallach, again, this isn't changing the existing grant program. It's just expanding the eligibility to this particular, the multi-generational third places.
That's correct. So there's a variety of ways the money can be spent. We're just saying this is another way that could be really beneficial.
Delegate Hill, did you have a question, or was yours?
I do.
Okay. Delegate Hill.
Thank you, Madam Chair. And thank you, Delegate Wallach. I have a particular interest in this because I carried the legislation establishing the grants in 2019 and 20 and 21, where we expanded it. We didn't expand it because we had to contract from the original appropriations to the 100,000, but we did specify in subsequent legislation that at least 20% would go for villages. And my understanding is that this is just clarifying what the villages can spend that money on. So my question has to do with, when originally introduced, we were also looking at non-village aging in place programs. So those not-for-profits in the community, that whether they're repairing homes or providing food, Meals on Wheels and that stuff, that could reach more people and provide more services if they were supported. I don't know if you can answer, maybe Ms. Wilbur could answer, at this point, how much of the funds are going to villages and how much are going to these unconnected, helping people in their homes to just age in place? Any sense of that? Because it was supposed to be about an 80-20 split. I'm really curious about what that split is now.
Thank you for that question. So in the current cohort, we have 3 grantees, and my understanding is I believe that takes the full $100,000. We were able in the last year to leverage some additional funding to make our pot a good bit bigger. So we've got 11 grantees, 3 of which are villages, but it's sort of the bulk of the funding. And that's been an intentional strategy, is to make sure that we are using these funds to support villages. However, there's a lot of village-like organizations. There's a lot of organizations that are doing community-led action, and those are also part of this grant. The grant eligibility is nonprofits, area agencies on aging, and 20% going to those defined as senior villages. So all of that is part of the review process.
Okay. May I have a follow-up? Okay, thank you. So it sounds like it's being really turned into almost a village's primary, and that's I'm sure fine. But the question I have now is, we've had other bills before this committee, particularly this year, where grant funds have asked for statutory changes to allow them to raise funds outside of general appropriations, to raise it from philanthropic organizations, et cetera. Is that something that would be of benefit for you all in these funds, or are you satisfied that they should completely depend on budget years and what we're able to appropriate year to year?
So first, just to reiterate, of the 11 grantees, only 3 are villages.
Right, got that.
But to your broader point, actually, that the other legislation that you're referring to, which sets up a special fund, the reason I got involved on that bill was because of this issue where aging in place is only funded at $100,000. And we were thinking about, how do we get more money to these organizations that are helping people stay in their homes and their communities? And one of the ways we thought about doing that is by creating that special fund. So it's very much the seed of that bill was this.
Got it.
The desire to fund these on-the-ground grassroots organizations helping our Marylanders stay in their homes.
So they're paired.
Very much.
Thank you.
I mean, that bill says the monies can go support everything that's in the Department of Aging statute. And of course, aging in place is part of that. And so I do hope in bringing this bill that some of that funds, if that bill passes and if that raises money, some of it can come towards this endeavor as well.
All right, thank you.
Thank you very much. Seeing no further questions, we do have one more favorable witness. This concludes the testimony of this panel. Thank you very much for your testimony and for this bill. Do I have Aram Abbasi? Aram Abbasi? You can begin your testimony when you're ready.
This is Aram Abbasi. Dear Chair and members of the committee, I am the Chief of Community Services representing the Baltimore County Department of Aging. I am here to support House Bill 811, the Village Multi-Generational Third Places Act. As you've heard from Delegate Wallach and my peers, villages do make a huge impact on the lives of older adults. Baltimore County itself is home to over 200,000 residents age 60 and older, and that's 1/4 of our population. As this number grows, aging in place must mean more than just staying at home. It also should mean staying connected with your community. As you've heard from my peers, social isolation is a serious public health concern linked to depression, cognitive decline, and chronic diseases. Access to welcoming community gathering spaces can be rich, life-changing for older adults, especially with those with limited income and mobility. HB 811 supports multi-generational third places, spaces like libraries, faith institutions, and community centers, where relationships are formed and belongings grow. Our villages already use these spaces to reduce isolation and strengthen communities. This bill provides needed flexibility to cover operational and rental costs, ensuring that grassroots organizations and culturally specific organizations can sustain these efforts. For these reasons, we respectfully request a favorable report. Thank you very much.
Thank you for your testimony. Are there any questions for this witness? Seeing none, thank you very much for your testimony. And this concludes the bill hearing on House Bill 811. We are now going to move to House Bill 945, which is Nursing Homes Complaints Notification and Consultation. Delegate Sample Hughes, if you'd like to come to the table and bring your panel, and you can get started with your testimony.
Good afternoon, Chair Bagnell, Vice Chair Cullison, and members of the Health Committee. It feels good to be back in this room. I feel like in my old stomping ground. Thank you. Today I bring before you House Bill 945. House Bill 945 is a simple but meaningful step towards strengthening oversight, accountability, and support for one of the most vulnerable populations, residents in Maryland nursing homes. The intent of this legislation is not punitive. It is not a gotcha bill. It is a partnership. Currently, oversight of nursing homes is conducted by the Maryland Department of Health through the Office of Health Care Quality. That oversight structure is critically important and governed by both state and federal regulations, including requirements that certain inspections be unannounced. However, in 2023, there were approximately 9,000 unanswered complaints related to nursing home facilities across our state. That number alone signals the current system is stretched and that we should explore additional layers of support and accountability. Now, I'm keenly aware that those number of complaints have reduced over time, but we're in 2026, and that had not been that very long ago. The new leadership, yes, Dr. Sullivan and Tia Witherspoon, who are at the helm making changes now, I'm grateful for that they're there. However, within that span of time, we've had deaths occur in the nursing homes. We have skin breakdown. We've had so many things that have happened, transfers from this nursing home to that one or to the next one. That happened in that time with this very same population. So House Bill 945 proposes that local health officers be notified when complaints are lodged against nursing homes within their jurisdiction. After meeting with the Maryland Department of Health, I understand and I respect their concern regarding the original language was requiring immediate notification. To address that concern, I am offering an amendment to change the notification requirement to within 24 hours of an initial investigation. Additionally, in recognition of federal requirements governing unannounced inspections, I am also amenable to clarify that notification to the local health officer may occur after a surprise inspection has taken place, so as not to intervene or interfere with the federal compliance or investigative integrity. The goal is not to disrupt OHCHQ's work, it is to complement it. Local health officers are uniquely positioned within their communities. That's why it's a little troubling to me sometimes to hear a health officer say, oh, that's not us, that's the state's problem. I'm sorry, I can't take that home with me and feel okay about that. But I do understand that local trends, they have access to available sources and community partners right there in the home place, in the jurisdiction, to help the oversight of the nursing home for those who are experiencing trends such as unusual spikes in urinary tract infections or bacterial infections, respiratory outbreaks, or other communicable concerns. The local health officer may already be tracking some of these issues already. And they very well may have a conversation with the local hospital to say, hey, there's something going on here. Again, local. The local awareness can provide early intervention support, epidemiology guidance, resource coordination, preventative consultation, collaborative problem solving. This bill creates an additional set of informed eyes, not to penalize, but to assist. It is about building a structure where the state is not the sole repository of complaint information, especially when we know the system is managing lots and lots and many thousands of unresolved cases. A local mechanism of awareness can strengthen response capacity without compromising existing regulatory authority. This bill does not have a fiscal note. It was noted that they can take on these tasks within their existing resources. And committee, we heard from so many people. I have a stack of them in my notebook today on letters. Some people terrified to testify. Some people okay to testify because their deceased loved one is now deceased. Their loved one is now deceased, so they're like, okay, I can talk now. They're scared, but they needed that entity to be able to have the extra level of eyes. The last thing I'll say in this is the theme, what we're hearing today is accountability, vulnerability. We're hearing all of these words, and it's the same message, is that we want the conversations to be solidified through this piece of legislation. So House Bill 945 reflects a belief that protecting our vulnerable nursing home residents requires coordination. I respectfully ask a favorable report on House Bill numbers transparency, 945. And I often sit every day with a picture of my mother on my phone, as well as my little dog, or she's not little, but a big dog. He goes to the nursing home on a regular. The patients and the staff, they know his name. His name is Hunter. And so I can just use that as another tool for comfort and for some outside love and support that our residents, I don't even know some of their names at the facility, but just to give them that level of support. And I think that we can do this by strengthening our connection with House Bill 945. Thank you so much.
Good afternoon. My name is Rose Cavanaugh O'Neill, and I'm here as a constituent advocate for the aging community. I've been working with the aging population for about 20 years professionally, and before that, as many of us do, as a family caregiver. And I'm here to support this bill, again, in an effort to improve communication and expand the use of resources, particularly on the Eastern Shore in our rural area, when there are a collection of complaints in one or more than one, either assisted living or skilled nursing facility. If we had our local health officers available to us as resources, I do believe that we would have a positive impact both for residents of those facilities, their families, their loved ones, and the staff that are running those facilities. During the COVID time, we worked very closely with our local health officers, with our line lists, and it was helpful, it was informative, and we had a lot of support. But communicable diseases are the only opportunity that I had to work with our local health department because they are not involved in complaints. And I do believe that if we had more information in our local county health officers' hands, we would have a better opportunity to support positive living outcomes for our aging population. And I yield back my time.
Thank you.
Thank you, Health Committee, for this opportunity. This testimony is in support of HB 945. My name is Ileana Kadushin. Since 2017, I have been the Executive Director of Stories Love Music, a 501c3 that has designed and offers a training program for professional caregivers who work with senior citizens in memory care units, assisted living, skilled nursing, hospitals, and private homes. I have seen firsthand how challenging working in senior care can be, how when those challenges are not dealt with have led to employee retention issues and a massive log of complaints in these nursing home environments. We are well beyond the tipping point. The OHCQ is leading the country in the percent of overdue nursing home surveys caused in part by lack of surveyors. Maryland surveyors are required to be RNs, and the RN continued staffing shortage has impacted the state's own oversight mechanism. Maryland is one of only 3 states in the country that have failed to conduct annual surveys in over 80% of their nursing facilities. Creating better channels of communication between nursing homes and local health departments to respond and consult with local resources is absolutely vital for this ongoing issue. I would like to also share the testimony of someone currently working as an employee. I'm a memory care director with much experience and certified dementia practitioners, 20 years of skilled nursing. The Maryland State Survey team is supposed to be helping us with these audits, while the real problem stems from staffing shortages. Many facilities I've worked in during our annual survey have gone through a change of ownership, change of staff, and don't take accountability for any of the complaints that have happened prior to the survey. And oftentimes documentation cannot be found about incidents, and new staff have no knowledge of how to prevent it from happening again. Thank you.
Thank you. And you have 2 virtual witnesses. Monica Brooks, if you want to go ahead and unmute and begin your testimony.
Thank you. Thank you, Chair Bagnall, Vice Chair Cullison, and members of the committee. I respectfully submit this testimony in strong support of House Bill 945. As a community leader serving families in Wacomico County, I have personally received concerns and complaints from residents and families regarding nursing home care. When loved ones are experiencing issues of neglect or lack of attention or harm, they reach out oftentimes to community leaders seeking answers. But too often we are left without clear information about how these complaints are handled or whether local health officials are engaged in the process. And that lack of transparency creates frustration. And we want to see stronger local involvement when serious allegations arise. Our local health department should not be on the sidelines when actual harm is being investigated within facilities operating in their own communities. House Bill 945 requires the Maryland Department of Health to notify and consult with local health departments when investigating complaints alleging actual harm. This coordination is critical. Our local health departments understand the history of facilities, maintain relationships with community providers, and are positioned to respond quickly when patterns of concern emerge. And their direct involvement strengthens oversight and ensures that accountability is not delayed. Families depend on long-term care facilities close to home, and they deserve to know that when they have a complaint that is lodged, that every appropriate level of government is informed and engaged. So House Bill 945 reinforces shared responsibility and ensures that local public health leadership has a seat at the table. This bill is practical and a necessary step towards improving transparency, responsiveness, and patient safety in Maryland's nursing homes. For this reason, Wacomico County NAACP asks for a favorable report on House Bill 945. Thank you for your consideration.
Thank you for your testimony. If you can just stay on until we open it up for questions. Wanda Mumford, if you want to go ahead and unmute and begin your testimony.
Good afternoon. My name is Wanda Mumford, and I was a daughter and caregiver for my father, Robert Anderson Jr., who was admitted at a facility in Princess Anne, Maryland on March the 22nd, 2020. After 1 week of being there, his glasses and hearing aids went missing. I complained and made several reports about him not being cared for properly because his hearing aid was gone, he could not hear. He was not being fed because he could not feed himself due to having dementia, and no one took the time to attempt to feed him. My sister and I both took turns going there during lunch and dinner hours to make sure he was eating. It got so bad that one of his roommates had called and left a message for me stating, "Miss Wanda, this is Christopher. I just wanted to let you know that I am supposed to go home tomorrow, but I really don't want to go because I don't want to leave your father. I feel he's being neglected." I had even asked the nurses, "Can you come watch me when I feed my dad?" All you would need to do was get up to my father's ear and say, "Dad, open your mouth," and he would open and eat. He was rushed to the hospital on 2 occasions. The first time it was August the 10th to August the 23rd, 2020, due to him falling. I was called in on that morning of the 10th and was told they could not find my father. By the time I got there, they found him in the floor in the bathroom. On several occasions, I complained about him not being bathed, and changed. One day, I observed a nurse come in to feed a roommate, and her phone rang. She got up and left the patient and was gone at least 45 minutes. I got up, found some gloves, put them on, and finished feeding the resident. I called the office manager the next morning, and she told me that she would handle that because staff wasn't supposed to be on cell phones. He returned back to the hospital on June the 23rd, 2020, with low blood pressure, severely dehydrated, kidney failure, rapid heartbeat. The doctor was very upset that my father was in the condition that he was, and even stated that he was being neglected.
Ms. Mumford, can you wrap up your testimony?
I'm sorry.
That's okay. Finish your thought. Thank you.
Before he was discharged from the hospital, I contacted social services there at the hospital to see if they had another place that my father could go to. But unfortunately, because he had dementia, there was no available room, so he was returned. I do have pictures before and after, but what I wanted to say was, I feel like my father lost his identity because in his last days, he could not see, nor could he hear. So the quality of life, I felt like he was a prisoner in a healthcare facility. Thank you for your time.
Thank you for your testimony, and we're very sorry for your loss. Thank you for sharing your very personal story. I'm going to open it up for questions from this panel, starting with Delegate Hutchinson.
Thank you, Madam Chair. Thank you, Delegate Sample Hughes, for bringing this bill. I'm very interested in this. As you know, we both share the two same counties, and this is probably one of my top complaints of some of the homes that are in our district. Yes. Yet, a couple things is that you're saying using the local health department. So have you talked to Matthew and Wacomico and Dr. Scott in Dorchester? My concern is their budgets are getting cut this year, which is unbelievable because of the amount of help they do. So you're saying it's funded, no additional resources. Are they really going to be able to take this on with the limited resource and the cuts they're having this year?
Sure. Thank you. Thank you, Delegate, for the question. So first, let me say this. I started working on this during the interim. And so at that time, we had the meetings with the health officer in Wacomico County. And unfortunately, I did get that response, that's the state, that's the state. didn't sit well with me, and I've spoken to others throughout the entire state as well. But what I will say is this, yes, it's a concern to see that any budget in our health space is potentially going to be cut because they need the support. But I can only go on what the fiscal note was, where it was stated that they can do this within the confines of the budget that they currently have. And I say because of this, I'm not asking for the health officer to go out there, be in the trenches day in and day out. I'm saying, hey, if there is something that you know of or see of is a trend that's happening specifically with that bacterial infection in Wycomico County, going over to Tidal Health Hospital, but, say, hey, is what's going on? Is there some other additional resources that you might need, nursing home director, or just really the resources that we have within our counties? There are programs and organizations that don't mind stepping into an institution to provide that additional level of support. We even have churches and volunteer organizations that come in and they can help lend us support in some things that are non-medical. So I hear you loud and clear, but I also know that these people we're talking about right now, they're not here much longer. And I work in the deaf industry, and I hate to see when somebody comes in with bed sores. Their days are over. So I get it, I understand about the budget, but I understand the reality of what we have to do. Just have some conversation and support one another so we'll know that what the state is getting, that this community in whatever jurisdiction, Garrett County, whatever, that the local person on the ground at least has some knowledge, and that they could be like, oh, well, let me help over here. I at least have this information to provide for this nursing home facility. I believe that's a fair place to be right now. I'll be honest with you, I wanted to go further. I like to go where Montgomery County is. They have taken over their division and things within their umbrella. And I know I don't have that space because we don't have the finances. But I think that this is a good starting point.
Thank you for doing this, because we have to do something, because just surveying and rating them without any teeth to do something is not enough. Thank you for bringing this.
Thank you.
Delegate Shalega.
Thanks, Madam Chair. Hey, good to see you.
Hey, good to see you.
Thanks for being here. So I, as Delegate Hutchinson, think this sounds like a great idea. And reading your bill and then the department's opposition, the department would welcome the opportunity to work with the sponsor and the committee to strengthen communication and transparency between OHCQ and the local health officers within our legal authority. So if I'm reading it right, the vision for your bill is when there's a complaint, they would clue in, they would notify the local health department.
Correct.
So you're not saying call them and say, Mrs. Smith in bed 5 has, whatever the complaint is. So why do you think they have opposed the bill?
Thank you for the question, Delegate. So it was a couple of things. I just received a letter of concern, and I have asked for a meeting well in advance to just go over what they might be. And after my meeting just on the other day, I was informed, okay, we'll talk to you on Friday or one day next week. I work with people, right? But I also know today was a bill hearing. So what I am saying is this. This has been in the forefront of the Maryland Department of Health. It's been in their knowledge bandwidth, because I brought it up during the interim and during the summer and saying, well, we need to have some level of way to solidify that these conversations that come up sometime with the health department, the health officer and the State Board of Health, that they actually happen, that there's some movement, that there's some notification. Again, I'm not trying to have them go out in the trenches in the streets and check on lady in bid 5. I just want them to be notified what's going on. We have these patients that are trending and going to the hospital for a bacterial infection, constant UTIs. And the previous panel on the previous bill had mentioned about why is the hospital asking these different questions? Because the hospitals, the doctors, they're concerned. Like, why are you a frequent flyer of the hospital when you're in a facility, a nursing home facility? So there's a problem, and we have to be in the position to require our Department of Health to step up to the plate and require the health officers to be a part of the process and not say, oh, this is not my area, that's the state. We all live here in this state, and we at least can take care of our older population. That's the minimum that we can do for people.
Thank you.
Thank you. Are there any further questions for this panel? Seeing none, I want to say thank you. I wanted to ask, you had mentioned amendments. Did you have amendments, or they're being proposed? If you could
No,
just
I
speak to
have.
the amendments.
Yes, Madam Chair. I do have the amendment. I can certainly make sure the committee has it. They prepared it on yesterday. It is within 24 hours of the initial investigation. Again, that's so there is no way for the OHCQ's process to be hindered, so they can go forth, do their investigation, and not surprise nursing home or take that power away from them. So that's why I said after they initiate it. And the last thing I'll say, I think there's a couple more virtual witnesses that are on, but we heard from so many people, and I'm just very appreciative. Thank you for allowing me to present.
We do have another panel of virtual witnesses.
Okay, thank you kindly.
But I also wanted to ask, because one of the things that we've heard in our briefing was that OHCQ is getting up to date with their investigations. However, they don't feel that they have the statutory authority for some of the enforcement. And I think perhaps their letter of concern speaks to that gently. Were you made aware of their concerns ahead of this hearing?
Yesterday.
Okay. So, and there's no cross-file for this bill, is that correct?
No, there isn't. There
Okay.
isn't. But when I was provided the meeting with them, it was specifically on the immediate notification piece. That's why I quickly got an amendment drafted to address that one right away. And again, they say that they have these conversations in their meetings sometimes and, have that, but there is a mechanism, but let's just make sure it's a guaranteed mechanism. So there is some level of communication for both entities and all those involved.
And it doesn't appear from the testimony that there is a concern about the local health departments having the authority. And if there was a concern, we could also statutorily give them that authority. Is that correct?
Absolutely.
So I'm hoping that you will continue to work with this committee, and we will facilitate some conversations because I think this is an incredibly important endeavor, and I really appreciate you bringing us the bill.
Sure, thank you.
Thank you very much. With that, we're concluding this panel. We do have a favorable panel. We have two virtual witnesses, James Jones and Angela Morton. Angela Morton, if you want to go ahead and unmute and begin your testimony. Ms. Morton, can you hear us? You can go ahead and unmute and begin your testimony.
Yeah.
Yes, you can go ahead and begin your testimony.
Hello?
Okay. You're unmuted. Go ahead and begin your testimony.
Okay. Thank you for the opportunity to lend my support to HB 945. We often use clinical terms like actual harm or level G deficiencies in these rooms, but let's be clear about what looks like behind closed doors. It is a grandmother lying in a soiled bed for hours because there isn't enough staff to help her. It's a grandfather suffering a preventable fall that breaks his hip and his spirit. It is a terrifying realization for a family that the place they trusted to keep their loved ones safe has become a place of danger. I, Angela Morton, have witnessed my great-grandparents, great-aunts, grandparents, father, and most recently, a close family friend pass away in a nursing home. I truly believe that if the family hadn't been visiting regularly, they wouldn't have lasted as long as they did. My great-grandmother and my father were given the wrong medications. My close family friend fell and went into a diabetic coma. When the state initiates an investigation into these tragedies, it admits that something has gone terribly wrong. To keep the local health department in the dark during that investigation is to leave a community unprotected. Nursing homes can become an island. I remember when my grandfather went into the nursing home, he stated, "This is the end of me." When a resident is harmed, they often feel isolated, forgotten, and powerless. My great-grandfather suffered bruises on his wrists because he didn't want to get out of bed. The aides would force him to get up. As a local safety net, the local health departments are the neighbors of these facilities. They are the people who live in the same towns and shop at the same grocery stores as the residents' families. Moreover, the local health department inspects restaurants and ensures they comply with local and state regulations. So why not add the nursing homes? To restore trust, families are often the last to know when a systematic investigation begins. By notifying local health officials, we ensure there is an advocate nearby who can talk to families and keep them informed and on top of it. Each day that a state investigation remains a secret from local authorities is a day that more residents are at risk. We often just asking for a change in paperwork. We're asking for a vow of transparency. We have a sacred duty to protect those who once protected us. When
Please wrap up your testimony.
Excuse me?
Please wrap up your testimony.
When we allow information to be buried in state files while a crisis unfolds locally, we are failing that duty. I'm asking that you see the faces of the mothers, fathers, and grandparents behind these case numbers. Please mandate that the state immediately notify local health departments that moment a resident is harmed. Let us ensure that no senior has to suffer in a vacuum of bureaucracy.
Thank you for your testimony. Are there any questions for this witness? Is James? Okay, let the record reflect, James Jones is not in the waiting room. Are there any questions for this witness? Seeing none, thank you very much for your testimony, and thank you for sharing your very, very personal stories.
Thank you.
This does conclude the hearing on House Bill 945. We are going to move now to House Bill 1068. Delegate Sample Hughes, it's lovely to see you back in this committee. You're home. And we are going to move to 1068, Health Insurance Special Enrollment Period for Newly Hired Employees of Small Businesses. Delegate Solomon, if you want to come to the table and bring your panel, and you can get started when you're ready.
Thank you, Madam Chair. Nice to see you all again, twice in 1 week. Appreciate the hospitality. For the record, Delegate Jared Solomon here from District 18 to present House Bill 1068. This actually is a pretty simple bill. This will be hopefully a shorter conversation than the bill we presented earlier in the week. This is a bill that we worked on actually in collaboration with the Maryland Health Benefits Exchange. This is an idea that they brought to me from the work that we did and this committee did last year on trying to extend and promote health insurance benefit exchange plans and pathways for childcare providers. And I also want to lift up, I know she's not on the committee anymore, but my dear friend and your former colleague on health or health government operations at that point, Delegate Robin Lewis, who was a champion on this work back in 2023, where this idea was included in one of her bills. Unfortunately, that bill had, I think, a $5 million fiscal note on some outreach resources, and we all know the budget didn't really have a whole lot of capacity for that, so sometimes really good ideas get caught up in big fiscal notes and then get tabled for a time. So again, this is pretty simple. We're trying to find to help sort of a small group of people here who kind of fall into the gap with health insurance enrollment. So this bill would create a new special enrollment period for folks who are being employed by a small business, so 50 employees or less, that don't already have coverage, and essentially you're going to hear some testimony, and there's some opposition testimony around sort of the duplicative nature of some of the existing special enrollment periods that we have already. Well, this is for folks who, if you're outside that window of a life event, if you lose your job and you're past that 60-day window, but then you want to take a job with a small employer, but that small employer does not offer employer-based health insurance, this would give you an option, create a new special enrollment period to be able to purchase a plan through the exchange or through private insurance. I know many of us this session are looking for ways that do not cost money. This bill doesn't have a fiscal note except for a minuscule amount that might be required for new programming and some administrative costs. But we are looking for either low-cost or no-cost ways to help small businesses, help folks be able to get access to insurance, and that's really what this is. We know that there's some really good stats in here that I won't bore you with, but basically, already small business owners struggle, obviously, with providing health insurance, and if you are a really small employer, so 10 employees or less, that is the least likely employer to offer health coverage. And so this is really trying to level the playing field in an easy way for, this isn't going to be a panacea. It's not going to help 100,000 Marylanders, but it's going to help a couple of thousand, we hope, maybe at most per year. But folks who, might consider going to work for a small business that doesn't offer care because they can get their health insurance in another company that maybe isn't as advantageous or as beneficial, but would offer the care for them. So with that, I'm going to pass it over to the Maryland Health Benefits Exchange, who has been a really wonderful partner, and I'm really glad that they brought this in. The one thing I will mention is there was a technical amendment that I think you all should have that was submitted by the Maryland Insurance Administration. We got it last night at about 6 o'clock, but they have been looking at this and they think maybe we missed a wording here or there for dependent coverage. So I think we're going to have a chance to look at that, but that seems like it's something that we would want to make sure we add in. So just wanted to draw that to your attention as well. Thank you.
Thank you. Good afternoon, Chair Bagnell, Vice Chair Cullison, and members of the Health Committee. For the record, I'm Michelle Eberly, Executive Director of the Maryland Health Benefit Exchange, and thank you for the opportunity to testify on HB 1068. As you know, the vision of Maryland Health Benefit Exchange is high-quality, affordable health coverage for all Marylanders. With that vision in mind, we support all efforts to provide access to Marylanders for health coverage in our state. Despite the recent federal challenges and obstacles enacted to limit health coverage for Marylanders, we found during our past open enrollment that Marylanders will do whatever they need to do to keep health coverage. They really want health coverage. And they'll make difficult financial decisions to keep that health coverage. We also know that through the exchange, once Marylanders have coverage, they keep their coverage. And in fact, 81% of our consumers renewed their coverage for 2026. There has been no evidence since the beginning of the exchange enrollments in 2014 that special enrollments cause any harm, whether that is for adverse selection or duplication of other special enrollments. It just is another opportunity, like we've been so successful with our check the box in our tax time filing and our our unemployment, just another way to get access to Marylanders. So for these reasons, we support House Bill 1068 as another pathway and another way to get more Marylanders covered in health insurance and to support our small businesses, which are always looking for ways to have a competitive advantage for hiring and retaining employees.
Good evening, Chair Bagel, Vice Chair Council, and the Health Committee. Thank you for the opportunity to testify on behalf of House Bill 1068. My name is James Earl Hollywood III. I am a Maryland resident, a nonprofit executive, and a professor working at the intersection of workforce development, public health, and community systems. In my work with small businesses and organizations and emerging professionals, I regularly see the structural gaps this bill seeks to address. Many small businesses in Maryland simply cannot afford to offer employer-sponsored health coverage, yet they are vital to our economy. They are child care centers, small nonprofits, local service providers, and community-based businesses. When someone is newly hired by one of these employees and coverage is not offered, that employee may not qualify for traditional special enrollment period. That can leave them uninsured for months until the next open enrollment. A new job should represent stability and opportunity. It should not create a coverage gap. From a workforce perspective, this matters. Employees who lack access to care are more likely for delayed treatment, experience preventable health issues, and struggle with productivity and retention. For small employers already competing for talent, this becomes another barrier. House Bill 1068 established a reasonable target 60-day special enrollment period. It aligns enrollment policy with real-world employment patterns. It supports small businesses without imposing new mandates, and it helps to ensure that new employees have a fair opportunity to secure coverage when they begin work. This is practically common sense step towards reducing the uninsured rate in Maryland and strengthening our workforce. I respectfully urge a favorable report on House Bill 1068, and thank you for your time and consideration.
Dear Chair Bagnell and members of the House Committee, my name is Gregory Dunlap, and I'm here to testify in support of House Bill 1068, which would create a 60-day special enrollment period in the individual market for Marylanders who become employed by a small employer that does not offer employer-sponsored health plans. I own a small business, an independent insurance agency. I am an authorized broker through Maryland Health Connection. Like most small business owners, I meet with them. They want to provide health care, but many cannot afford the cost of the plans that attract and retain top talent. They're competing against well-established, financially backed employers that can offer coverage and can pay most of the premiums, if not all of the premiums. Small businesses just don't have that margin. I lead with qualified plans through Maryland Health Connection, and if necessary, I'll introduce level-funded plans as a potential savings workaround. But level-funded works best if the employee group is unusually healthy. And I don't get to meet many of them in my communities. It's not a realistic expectation. If underwriting comes back high, the employer is right back to unaffordable premiums. This bill creates a practical and achievable solution by establishing a 60-day special enrollment period for newly hired employees of small businesses that don't offer, and in many cases, may not be able to afford to offer adequate coverage. It allows those employees to immediately access coverage through Maryland Health Connection instead of waiting for the next open enrollment period. That flexibility gives small employers a better chance to compete for talent, grow their businesses, contribute more to our state economy, and reduce gaps in coverage that often lead people to rely on emergency rooms for basic care. I urge you to favorably report on House Bill 1068. Thank you.
Anybody else on your panel?
I think this is it.
Okay. All right, then I will open it up for questions from the committee. Seeing none, maybe. Delegate Hutchinson.
I'm still sort of trying to figure out.
Yeah.
Working. So an employer, I don't know who's going to answer this, delegate, perhaps I'll direct it to you, but that someone comes to your place of business to be employed, who's actually paying for the plan, the employee or the employer?
So this is actually only if you are, that's a great question, I appreciate the clarification. It's actually only if that employer does not offer coverage. So it's literally all this is doing is saying, if you have sort of missed, let's say you lost your job and there's the traditional special enrollment period for somebody who's had a significant life event. 60 days pass, maybe it takes you 4 or 5 months to find a new job. You don't have insurance during that period. You couldn't afford COBRA, you chose not to do it. You find a job at a small business, but that business does not offer insurance. You can then go onto the exchange or into the private market and purchase insurance on your own. It essentially gives you that that special enrollment period instead of having to wait until the next open enrollment period.
Thank you. I think you clarified it with the COBRA aspect of it too, which was going through my mind. I appreciate it. Thank you.
Delegate Gazzoni.
Thank you, Madam Chair. I think this is probably for Ms. Everly. Do we have a sense of how many people this might affect?
I don't have the exact numbers of how many people this will affect. We don't anticipate a huge uptick or impact, but it just again, opens another door. So we have our, our full portal for our small businesses and for those that really want to offer coverage, but this is just another opportunity to allow someone to get health coverage without having to wait till the next open enrollment cycle.
Okay, thank you.
Mm-hmm.
I should have mentioned, Delegate Gazzoni, I believe this was part of the recommendation from the 2023 sort of task force that looked at how we can improve access enrollment through the exchange. And again, it was part of the bill that Delegate Lewis brought. But again, the bigger part of that bill was a significant infusion of funds into outreach. And so it got kind of caught up in that, which had a really big fiscal note.
Thank you very much, and thank you for the bill. I wanted to give you a chance to answer. Actually, I'm going to direct it to Ms. Everly. Kaiser's testimony says that this is redundant, that the loss of minimally essential coverage qualifying life events already provide 60-day window under the individual market. For employees of small businesses that do not offer coverage, Maryland already provides year-round enrollment opportunities for those who qualify for Medicaid, or those with certain income thresholds up to 200%, of course, which is not everybody. And that easy enrollment programs, Maryland is a national leader in easy enrollment. So they're saying this is redundant. What would you say, Ms. Everly?
Well, it's not redundant in the situation where, again, we're talking timing. Somebody loses their job, they can't afford COBRA, we know it's very expensive, they don't have any other option, so they go without coverage. And then they get a job and that employer does not offer coverage. So that in that situation, it's not duplicative. Yes, if somebody loses minimum essential coverage and they've had coverage, there is a window that they can get that special enrollment. But if they're outside of that window, then they have to wait till the next open enrollment period. And it just, we have many different special enrollment periods. So, I guess you could say they're all duplicative because they're special enrollment periods, but it's just another way to provide access, and we don't see any downside to it in terms of the level of effort for the exchange to implement. It's not, not anything big. For the marketplace, it's again we don't expect any adverse issues, so it just is another opportunity to make sure people can get coverage.
Okay, just sewing up that safety net.
Okay. Yes, exactly.
I like that, Delegate. Thank you.
Delegate Riley.
Thank you, Madam Chair. I think my question was answered, but so just to verify, because I was thinking, okay, when a person loses their job, they would automatically get qualified for COBRA. So in that aspect, you're saying the COBRA insurance is a lot more expensive than what someone could purchase off of the exchange?
Well, we typically tell people, I can't say in every instance, but we typically tell people, compare your COBRA against what you could purchase on the exchange for, because COBRA typically is expensive. It's whatever the employers, and then there's an increase on top of that. So again, if somebody's lost their job, and it may be, they may even be able to afford that for a short period of time, but if they're out of work for any period of time, and they can no longer afford it, then they're without coverage.
Well, isn't COBRA, the benefit for having the 60 days for COBRA, whether you can afford it or not afford it, like you said, they may try, is to have that time frame to look for insurance, permanent insurance? And now you want to give them another 6 days on top of that 60 days?
I think there's a couple things. So there's one with the COBRA with the employer. When you are terminated from employment, some employers give you the option of COBRA, not all, but some, and I don't know the rules well enough around that. Then the other is you can go out and purchase it on your own. But if you're in that gap where you're not working and you don't have enough money to pay for health insurance, whether it's through COBRA or through buying it directly off the marketplace, but now you get a job and you now have that income coming in, but you've missed that special enrollment period, this just allows you an opportunity to now purchase that health.
Thank you for the explanation. I appreciate it. And thank you for the bill, and thank you, Madam Chair.
Madam Vice Chair Cullison.
Thank you, Madam Chair. Thank you for being innovative, trying to be innovative here, but I'm guessing, I'm questioning whether or not this is just an open enrollment, always, no matter what. I mean, it doesn't really specify the person has to have had a job with insurance and then goes to another job without insurance. You have an open enrollment period. So it's like it will. It seems to me the way the bill is worded, but help me if I'm misreading it, that basically anytime a person starts a new job, there's an open enrollment period for the, and if the job doesn't offer insurance, there's an open enrollment period for them. And
for
isn't that
60
already
days.
true? I mean, so say I graduated from college and I went to go work at a small business. So I haven't worked, and maybe I was covered under my parents or not, but wouldn't I have 60 days at that point to look for insurance on the exchange?
It's not a special enrollment qualifier if you are not employed and you're uninsured, and now you start employment with a small employer who doesn't offer health coverage, but it's outside of that open enrollment period and it's outside of all the other special enrollments that we have, special enrollment periods. This would just open up a special enrollment period for 60 days that acknowledge you're now working, you now have an income, and will help you get health coverage.
So it doesn't currently exist?
Correct, that is correct.
Okay, all right, thank you, thank you.
Seeing no further questions, I just wanted a clarifying question, sort of dovetailing on Delegate Riley. So if you do have if you do COBRA, say for that first 60 days, while you're shopping, the end of the 60 days of COBRA, that wouldn't start another special enrollment like that. You could be shopping with your new job, with your COBRA insurance,
Right.
as sort of the bridge.
There are special rules around COBRA, and if you commence COBRA, I believe you have to exhaust your COBRA before that opens up a special enrollment period.
Okay, got it. Thank you. That is very helpful. Seeing no further questions, this concludes this panel.
Thank you, Madam Chair. Maybe I shouldn't have said it was a simple bill. Thank you.
But we have one unfavorable panel. Did I miss? I have two more on your sponsor panel, Joanna Fabian Marks and Gregory Dunlap.
I did the testimony for the exchange.
Oh, okay.
Yeah.
Okay. And Stephanie Clapper. Okay, there we go. So we've got another favorable, and then we'll go to the unfavorable. Thank you.
Madam Chair, Vice Chair, and members of the committee, I'm Stephanie Clapper, Deputy Director at Maryland Healthcare for All, and thank you for the opportunity to provide supportive testimony for HB 1068. Maryland Healthcare for All works towards quality, affordable healthcare for all Marylanders, and our coalition is made up of hundreds of faith, business, labor, community, and healthcare organizations across the state. Under your leadership, Maryland has cut its uninsured rate in half in Maryland from 13% to 6% and reduced uncompensated care in our state by $460 million, which helps stabilize everybody's health insurance premiums. This progress is being threatened by federal attacks, including H.R. 1 and federal administrative rules that are causing Marylanders to have to jump through more administrative hoops to gain and retain their coverage. This legislation represents a way that the state can help new employees of small businesses and small nonprofits quickly access health coverage when reducing administrative hurdles is more important than ever before. This legislation would help new employees get health coverage they need to remain healthy and productive after they are hired. Only about 1/3 of Maryland employees at organizations in the private sector with fewer than 10 employees report that they are offered employer-sponsored health coverage. And this is a matter of equity, as Maryland is the leader in the entire nation for businesses, small businesses owned by people of color, and disparities in access to health coverage continue to persist by race and ethnicity. Maryland Health Benefit Exchange has made consistent outreach efforts over the last few years to small employers to educate them about both small group options and options for their employees in the individual market. However, for new employees, that start at small employers that do not offer small group coverage, employees may have to wait as long as 12 months to enroll in health coverage until the next open enrollment period. By creating this special enrollment period, this bill would help shorten coverage gaps and help small employers attract talent during a time when federal actions threaten to reverse all of the healthcare progress that Maryland has made. We urge a favorable report for House Bill 1068. Thank you for your leadership and consideration.
Thank you for your testimony. Are there any questions from the members for this witness? Seeing none, thank you very much, and sorry I was struggling reading my notes. Now we are going to go to an unfavorable panel. We have Allison Taylor, Matthew Celentano, and Kimberly Robinson. You can come to the table and begin your testimony when you're ready.
Good afternoon, Madam Chair, members of the Health Committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers in opposition to House Bill 1068. First and foremost, I want to thank Delegate Solomon for sitting down with me to talk through our concerns. And as much as we like to support this bill, we cannot at this time. And I think, as you've already heard, it's a little more complicated than it appears. In general, special enrollment periods center on risk management, cost predictability, and market stability. Our concern that a new special enrollment period encourages adverse selection, where individuals enroll only when they expect the highest medical costs. This in turn leads to higher claims expenses for the entire market, which leads to spreading that impact and higher premiums for the rest of the market. As I think it was alluded to a little bit before, there are already a lot of triggers for special enrollment periods as established by the Affordable Care Act, which we believe make House Bill 1068 unnecessary. You're eligible for a special enrollment period now if you lose coverage when you turn 26 and get kicked off your parents' health insurance, if there's a change in your household, a death in the family, adopting a child, having a child, a divorce, etc., change in your residence, an income change that would impact your subsidy, pregnancy, immigration status. We don't believe we need an additional special enrollment period that threatens risk distribution. Also, as you heard before, Medicaid has no open enrollment. It's continuously open. So if you are in a position where you didn't have a job, you're probably in an income area where you would be eligible for Medicaid today. We respectfully ask for an unfavorable report on 1068, and we urge the committee to not move forward with this bill. Thank you.
I'll go next. Good afternoon, Madam Chair, members of the committee. Kimberly Robinson on behalf of Care First Blue Cross Blue Shield, respectfully in opposition to House Bill 1068. I won't repeat the comments that Mr. Celentano said, although we do agree with his assessment of the bill. The one thing I would add to it that definitely stood out to our folks who are most familiar with this and work in this particular area were questions around how one would prove their eligibility for the special enrollment period. So for any of those particular situations that Mr. Celentano called out, we are required to confirm that the person actually qualifies for that special enrollment period, and the bill is silent on what that would look like in this circumstance. So I will just simply add that to his comments and not belabor the point. And with that, we urge an unfavorable report.
Good afternoon, Madam Chair and members of the committee. For the record, my name is Allison Taylor. I'm here on behalf of Kaiser Permanente. I also will not repeat what my colleagues said, other than to Delegate Hill's point, I will follow up with Ms. Eberly and we'll discuss the parameters of this.
Thank you for your testimony. I'm going to open it up for questions from the members, starting with Delegate Hutchinson.
Thank you, Madam Chair. So Matt, if I understand this correctly, so in this, you're saying an individual who probably didn't have health insurance prior gets a job, but may want to go on to this plan because they're potentially going to have a health issue that creates higher costs, which would drive up the cost of health care versus, I'm just trying to understand, is that what you were saying, that the real issue is in that case there? That
Yeah, the wonky term is adverse selection, but we sort of refer to it as cherry picking. And as for folks, if you have continuous open enrollment, there's no incentive for you to pay premium unless you're sick, right? So you're not going to get that insurance until you're sicker, which drives the claims cost, which impacts everybody who has insurance.
Great, that's the term I was looking for. Thank you.
Delegate Hill.
Shout out of appreciation for actually having written testimony that we could see. No shade. Matt, I want to sort of follow up on Delegate Hutchinson's question. So what you're saying is that, as written, this bill says an individual becomes employed by a small employer that doesn't offer health insurance. And you're suggesting that the cherry picking would be they wait till they're sick to get a job with a small employer, and they look for a small employer who doesn't offer health insurance so that they can then get health insurance?
Well, I think that's one potential impact, but if you get sick, if there is a special enrollment period, you could just find another job, trigger another special enrollment period, and then get coverage. So there's no incentive to actually get coverage before there's the sick event. The other problem we see with this bill is that if we are providing open enrollment, whenever you get a new job, there's potentially the small group market. In the small group market, employers not offering coverage anymore and sending people to the exchange, which could be an unintended consequence. And as you know, Delegate Hill, you've heard, and this committee's heard over years and years, we see the individual market gaining market share and the small group market reducing. You actually have a bill later today that's going to have a study about the impact of what those shifting costs are. Could be a concern, and that's something that we want to be very aware of because of the declining enrollment in the small group market.
May I have a follow-up? I thought the goal was to try and get as many people insured as we can have insured.
Absolutely.
So,
I mean, we're health insurers at this table, right? So we want to sell more policies, not less. But we want to be very aware of taking the sickest risk on at the wrong time, so to say, quote unquote. There's no right time to get sick or wrong time, obviously. But we don't want people sort of cherry picking the system to get care and not providing premium when they're healthier, because it just messes up the risk and morbidity score of the entire marketplace.
and if I can conclude, all right, so I want to be clear. So what you're saying is this person who's getting a job with a small employer who doesn't have insurance, we would rather that this impending illness that they're cherry picking for happen to them uninsured than that they actually get insurance.
I'm not suggesting that, Delegate Hill. I'm suggesting we want everybody to get coverage to the open enrollment period to make sure that they have the protections that everybody should have with insurance in case something bad happens. But we don't want folks to be able to cherry pick the system. As you know, a lot of young people don't get health insurance. They don't see the value in it. And we want to encourage everybody to get in. And that's why you've seen young adult subsidies come out of this committee, how we've done special enrollment periods for life qualifying events, which we believe there are a robust amount of ones that are there now. This one creates kinds of mechanical issues that we're concerned about.
Thank you, Madam Chair.
Thank you. I'm going to take a third bite at that apple because you all deferred to Mr. Celentano's testimony, and I think you might have started with the argument about concerns about the small group rather than starting with the argument that folks who were uninsured were going to take a job with a small business that does not provide health insurance when they are very sick to get insurance through this open enrollment. I think you had spoken to a concern about, it's adverse selection, but there was also the question about the bill being silent on what are the factors to make the determination about eligibility. Have you, I think Allison, I think you spoke to that.
It was Kim.
It was Kim, okay. And I'm wondering if you have reached out to the bill sponsor and/or the exchange to talk about what kind of language you would need in the bill to make it clear what the eligibility determination would be.
I haven't had that conversation yet. It was something that our team came back with. It was a later thought, but I absolutely can. They want to be sure that with other things, you have to justify that you meet the requirement, right? So what would be the thing that the exchange would look for to verify that, I'm going to pick on her because she's sitting next to me, that Allison had been unemployed, took a job with a small employer who's not offering insurance, and what will that small employer be prepared to provide to prove that she's just started that job and they don't offer insurance. It doesn't mean it has to be a lot, but it means it's something that has to be collected, right? So we can certainly have that conversation.
Yeah, I think if we can get the language, I think that I suspect that the sponsor of the bill would be, amenable to further conversations. I see no further questions, so this concludes this panel and also concludes the bill hearing on House Bill 1068. We're now going to move to House Bill 931. This is Healthcare Facilities, Nursing Homes Medical Director Requirements. Delegate Hill, if you want to come to the table and bring your panel, and you can get started when you're ready.
Okay, you're good. Just want to make sure I've got the right bill in front of me. All right. Just hope I didn't poison the well on the unfavorable panel. All right. Good afternoon, Madam Chair, Madam Vice Chair. My name is Terry Hill, and I'm here to present House Bill 931, Nursing Home Medical Director Requirements. Basically, 931 strengthens the oversight and quality of care delivered in Maryland nursing homes by ensuring that the physicians who are serving as medical directors meet some basic level of training in terms of how you actually manage in a nursing home. The bill requires physicians to receive a certified medical director credentialing or some equivalent. And it also provides for a time frame for people who are serving as medical directors now to acquire that certification. It then goes on to limit the number of facilities that a person can serve as medical director of. Pretty uniformly, that provision has proven problematic, and I'm offering an amendment to remove it. What I had talked to both the stakeholders who were in support of the bill with the amendment to remove that minimum requirement, and those who were even in opposition, is that perhaps I agreed that the 2-facility limit was a little restrictive and had offered instead one that was based on the number of beds of a facility. But what I've been asked to do is just completely take it out and allow the people who are the experts in this field some time to work out what an appropriate limit based on such criteria as severity of the care of the patients requiring care in the facilities and the number of beds. And so perfectly willing to do that. There's also a suggestion from the Board of Long-Term Care Administrators that we increase the time period by which medical directors currently filling those roles can get certified from 2028 to 2030, and I'm fine with that as well. MDH has asked that the requirement that they produce a medical directory of the directors be removed, and instead the long-term care facilities, nursing homes be required to post on their website who their medical director is, which is certainly a way to make sure that information is known and can be updated in quick time and become kept contemporaneously, and I think that amendment would also take our fiscal note down. And with that, those three amendments, I would ask for a favorable report.
Okay, so I'm not going to start my speech. I know I have only 2 minutes. This is my first time here, and I was sitting back and reflecting, and I was feeling very hopeful. I was feeling very hopeful that we are here to take care of older adults and vulnerable people, and we are talking about nursing homes and how we can improve the quality care.
Now, give your name. Give your name.
So now I'm going to start my speech, but I want to share with you that good afternoon, everyone, and Delegate Chair Bagnell, Vice Chair Cullison, and all the members of the Health Committee. I really want to thank you the opportunity that you gave me to testify in support of the bill with the amendment which has already been shared. So my name is Fatima Naqvi. I am the Assistant Professor of Geriatrics and Palliative Care at George Washington University. I'm also serving as a president of the Mid-Atlantic Society for Post-Acute Long-Term Care Medicine. And that is an organization that represents clinicians from the, who are the medical directors and physicians who are practicing in Maryland nursing facilities. I'm also a certified medical director, have been working in Maryland for the last 14 years. There's an old saying, an ounce of prevention is better than a pound of cure. And that's what I was thinking in the back. A colleague of mine, a certified medical director in a nursing home, led a comprehensive medication review, and over the course of 1 year, she saved $3 million. And she also reduced burden bill, she improved the quality of care, hospitalization, and readmissions. Since 1987, the federal law that required a medical director to work in a nursing home, some of them have never stepped in a building. And we are struggling how we can improve patient care and quality improvements. So I feel this bill will really support us. Other states, Florida and California, has already this bill passed. I feel Maryland should be the third one. Thank you so much for this opportunity. I'm running out of time, so I really want to thank you for the support, and I respectfully encourage all of you to accept the bill with the amendment that was just suggested. Thank you.
Good afternoon, everyone. Respected Madam Chair, Vice Chair, and members of the committee, I appreciate this opportunity to give testimony in favor of this bill. I'm Dr. Fatma Sheikh. I am an internist and a geriatrician. I've been working in post-acute long-term care for the last 13 years. I'm a certified medical director. So when I took on a job in post-acute long-term care, I became medical director of 2 facilities. This was fresh out of fellowship. I did not have any tools to lead the facility. I took the course for certified medical director, and the skill set that the curriculum gave me was instrumental. It helped me with the things that I needed to do. It helped me get the education and knowledge that was very valuable. That included how to lead the physician services in my facilities, how to look at copy, which is a quality improvement processes, looking at areas which needed strengthening. The things that was important to the patients and families. To work on those things was very, very important. So looking at unplanned transfers, looking at unnecessary medications, looking at why falls are happening in the facility, how to improve wound rate. So those are all things that are important for the oversight of a medical director. So studies have shown that medical director who is certified can improve facility performance, reduce hospitalizations by 7.8%, and decrease ER transfers by 21.6%. That's huge. Those are huge numbers. What I feel with this bill, we are including transparency and accountability so that the medical directors in the facilities that are certified is available to the community, to the patients, to the residents, and to the families. So I request a favorable support for this bill. Thank you.
Good afternoon. Good afternoon, Chair, Vice Chair, and members of the committee. Thank you for the opportunity to speak today. I'm here in support of the amendments of HB 931. My name is Dr. Sadia Bakai, and I am a certified medical director. Serving as a medical director in a nursing home is not a ceremonial role. It is a position of accountability. Medical directors shape clinical policies, oversee quality improvement initiatives, guide antibiotic stewardship, address polypharmacy, and help facilitate navigate complex state and federal regulations. These responsibilities directly impact patient safety and outcome. Yet most physicians receive little to no formal training in how to carry out these administrative and regulatory duties. Certification bridges that gap. It provides structured, evidence-based prep so that medical directors are equipped not only to care for individual patients, but to lead systems of care within their facilities. When leadership is strong and informed, facilities perform better clinically, operationally, and ethically. While we support the intent of HB 931, we respectfully request reconsideration of the proposed 2-facility cap. Maryland faces ongoing workforce shortages, particularly in geriatrics. Facilities differ widely in size, equity, and infrastructure. A fixed number may unintentionally create access barriers in communities that already struggle to recruit experienced physicians and medical directors. We urge you to support certification requirements while allowing flexibility in facility coverage to ensure residents across Maryland have access to qualified medical leadership. Thank you for your consideration.
Thank you for your testimony. I'm going to open it up for questions from the members. Delegate Hutchinson.
Thank you, Madam Chair. Thank you, Dr. Delegate Hill, for bringing this bill. So every time I've ever heard the term medical director, I always have assumed that that is a physician that's in that role, and I may have missed this. So in cases where it's not a doctor, who's actually playing the role?
So a medical director in these situations is a physician, but they're not necessarily trained to be a medical director. So I know I have colleagues, for instance, who were surgeons, internists, pediatricians, and at some point in their career are offered an opportunity, or it makes sense for them for whatever reasons to take on a role as a medical director. And what you've heard these women who are physicians and who are certified medical directors testify is that you actually need special skills and training, just like any other specialty field. We should be making sure that the people who are giving these responsibilities actually have the training to do the job.
So you want everyone has to be trained as a medical director. They're
Certified,
physicians, but they have to be
correct,
certified.
certified as a medical director.
Thanks for clarifying. Appreciate it.
Can I say
No, unless someone asks you a question, so it's one person. Okay.
Delegate Riley.
Thank you, Madam Chair. So basically what you're saying is you want the MDH, they're being charged in this bill to come up with the regulations for a certification
No.
for the medical director?
The certifications already exist.
Okay.
There's already an organization that can.
Which is the online program,
right,
so that's
and-
already there.
And it's a respected organization, but it also says that if there are other entities that can also give the certification, so it's not saying only this organization, but it already exists, so the MDH doesn't have to create it.
Okay, so the program's already, or certification process is already there. And how many states, just as a follow-up, are actually doing this now?
Can I
Yes,
say now?
yes, you may.
Yeah, so Florida and California already has this regulation that a medical director has the certification, and it will enact, I think, in 2026 or 28. So they already passed the bill and they're working towards it. And really the goal is for a medical director to work in places like that, you need a lot of other things in leadership, which is emotional intelligence, cultural intelligence, having the sensitivities of how to manage all kinds of staff at all level, and that really need an expertise and the skill. So that's what we have been trained, and just clinical care is just one part of the big game that we have to deal with. So that is why we are standardizing the processes. We really want to standardize the processes so we can uplift the level of care and quality assurance processes, and it's very cost effective too.
Thank you very much. Appreciate it. Thank you.
Delegate Gazzoni.
Thank you, Madam Chair. So I was looking at the Health Department's letter, which indicates that the...
Closer to the mic.
Sorry, lift it up and speak right into it. I was looking at the Health Department's letter, and which indicates that medical directors are already required to be certified. And so I actually looked at it because they had the citation for COMAR, and it does say right there, medical director qualifications, and what a nursing home shall have one that has the qualifications, which includes the post-acute and long-term care medicine cert that's in the bill. So I just wanted to check on that part of
Can I answer that
your bill
question?
as to whether or not there's some mismatch there about it not counting.
Thank you for that question. So actually, Maryland was the first state to recognize that medical director needs special training. So current COMAR has the education piece, but it doesn't have the certification piece. So, so we are asking to add the certification piece to already existing education. So just a little bit clarification to what MDH had said about it. So certification is not required, only education is part of the COMAR. So what we are saying is that adding the certified medical director piece will add transparency and accountability, and having that repository of people who are certified will help the patients and their residents to know who is actually leading the facility. So we are hopeful that this extra step will bring more quality because we are making it more standardized.
Can I follow up? Okay, great. Happy to handle.
I think what you're saying is that in COMAR, it requires the medical director to complete a curriculum, the education piece, but it does not require them to have the certification, which is the second part. So the bill is requiring them on top of the education to get certified.
Do you have a follow-up? Yes. I just want to get clarification on that.
Yeah, she just confirmed what you said. Misunderstanding on my part. Taking the course does not, at the end of the course, it does not lead to has certification. There's not a certification step. Lots of times when you take a course, then you finish up and you take a test and there's a certification that you get. It doesn't, that's not what happens here.
So certification is not required after taking the course. So this just adds extra step, making it mandatory, because people who are taking the course, they're already engaged in the course. If they do take it, again, we found out that there are medical directors practicing in Maryland who actually have not even gone through any formal training, and facilities are not even aware to ask for that training, whether the medical director has had any kind of training which is more structured. So what we are asking with this bill, adding the certified medical director piece adds accountability, because facilities, they need to ask for that extra step.
If I can chime into that.
I'm going to ask if you can add a little bit more, but let me also get some clarification, because I think our concern and our confusion is to Delegate Gazzoni's point that generally when you take a course, then there's like an exam and you get a certification. So would this invalidate the eligibility of sitting medical directors who have taken the course, but do not have the certification, and what is the bridge to ensuring certification?
Thank you so much. This is a very important question. I think we do need to know. So taking the course and then going through that process is not an actual certification. In order to certify to be a medical director, you have certain number of education hours as in the education, practice management, leadership skills, and then these are the components. And after that is a committee that decides that, okay, now you are certified. Once you are certified, you have ongoing education processes that you need to follow through to stay and keep your certified medical director title. So going through education, that's what we have been one of my very good colleagues is the one who went to this and passed this. He's moved on, and we are following his legacy, Dr. Steve Levinson. And we have been working on for 20 years that we try to implement this, but this is not happening. And that is exactly why we are trying to benchmark it and make it as a mandated certification processes. As my colleague is saying, we have a lot of medical directors who don't even know what to do in a nursing home. So this is education, but followed through with specific steps that would make you an expert into working in these facilities.
Thank you for that clarification. Delegate Hill, I just realized you do have Dana Kaufman on your sponsor panel.
Okay.
Do you want Dana to come up and give her testimony? Because she also might have answers to some of our questions as well.
She'll pull a chair up. Just pull one of those chairs up.
I didn't see it because it was favorable with amendments and I got confused. So my apologies.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. For the record, my name is Dana Kaufman. I'm here on behalf of Lifespan Network. We are in support of the bill. We appreciate the amendments that were put forward. Our main concern was the 2 nursing home limit, but that sounds like that has been taken care of. For the first time, I did hear about the extension to 2030, which we would support, but then also the department asking to remove the online directory and have the nursing homes post the name of their medical director on the website. On that one, I do need to go back, and I will do that promptly. When I look at this and I look at the regulations, I can see why there is some confusion between the bill and the regulations. What I think that this bill is really doing is kind of closing that loop. The regulations actually never use the term certification. It uses approved curriculum and things along those lines, but it never specifically says that you have to have a certification. So this bill really does close that loop. What is reassuring, though, when we did a survey of our membership, the majority of the medical directors did have the certification, but there were some that did not. So this bill would then give them the opportunity to go get that certification in a timely manner. So we do appreciate that, that lead-in time to do that because, of course, we are short-staffed and it's hard to find medical directors. So hopefully that kind of cleared up that little bit of confusion.
Vice Chair Cullison.
Maybe just because it's late in the day or my brain cells aren't working, but I'm still not understanding what the certification process is. What is it? Is it paperwork? Is it an online course? Is it, is it submitting information to OHCQ that says, I meet these requirements? What is the certification process itself?
So thank you for that clarifying question. So the course anyone can take if they want to be a medical director, but to become certified, there are additional items that they need to qualify for. One is they need to be working in post-acute long-term care setting for 2 years as a medical director. So, or it could be if they have had any training in post-acute long-term care. So that actually adds to the eligibility. They also need to take the course. The course is mostly online course, and the course is focused on essential items of leadership, infection prevention, oversight of physician services, regulations. So basically, a lot of focus on regulations and background of those regulations. COPY, which is the quality assurance performance improvement activities, and how to perform those to improve quality of care in the facility. After the course, there is a practicum. So practicum is the participants, they are required to do a project, maybe fall prevention, maybe some other area that needs attention, and they need to use those tools from the curriculum to see the outcome, a positive outcome. If they're not able to see positive outcome, then to explain what were the barriers. So basically, it provokes positive thinking, critical thinking as to how they need to navigate through the real life issues when they are being a medical director. So once those criteria is filled, then they can apply for the certified medical director. And that's a certificate that is given by this organization that has already this curriculum.
And then there is one more.
Only one person. Thank you. I think I have it.
Delegate Kaufman, did you have a question?
Oh, it's okay. I was going to give her a chance to answer, but yeah, I was late.
All right. Seeing no further questions, thank you very much for your testimony. We do have one more favorable with amendment, followed by favorables virtual. So if I can bring Allison Siborowski. Thank you.
Hi, good afternoon. Allison Siborowski here today on behalf of Leading Age Maryland in support of House Bill 931 with the amendment to strike the 2 nursing home requirement that I know has already been discussed at length here today. I'll just say ditto to all of the great comments that have been made before me. I think this is an important bill to clarify that certification is an expectation in Maryland and that would positively affect quality of care in the state. So thank you. We urge a favorable report with amendment on House Bill 931.
Thank you for your testimony. We're always happy with a Me Too. Are there any questions from the members for this witness? Vice Chair Cullison.
Thank you. Sorry, Allison. So who issues the certification? Is it MDH, OHCQ? Who issues it?
No, it's a national organization. I'm going to mess up the acronym. Post-acute long-term care. I'm sure the sponsor knows. But it's a national organization that this is not just a state-level certification. It's a national certification.
Okay. Thank you.
Thank you very much for your testimony.
For the record, Madam Chair, as in the bills, the Post-Acute and Long-Term Care Medical Association, which is called PALMED, or as it says, a credential equivalent to a CMD certification.
Thank you very much. Thank you for the further clarification. We do have 2 virtual witnesses. They are both favorable. So if we can bring up Clifford Nelson and Hemad Khandeti. Okay. And Mr. Nelson, if you want to go ahead and unmute, and you can begin your testimony.
Sure, thank you, and good afternoon. My name is Clifford Nelson, and I'm the CEO of Psychogeriatric Services. We have a team of over 100 psychiatrists, nurse practitioners, and psychotherapists that provide mental health services in nursing homes and other long-term care facilities. And thank you for the opportunity to testify in support of House Bill 931. I also support the amendments that have been mentioned. Last year, PGS served more than 15,000 patients in the state of Maryland. We visited approximately 130 facilities ranging from Garrett County to the Eastern Shore and everywhere in between. And our team of specialists supports medical directors. We don't serve as them. And we advise on conditions including dementia, depression, anxiety disorders, substance use, and more. Medical directors have a really tough job. they need the training, understanding, and systems to manage a complex array of health issues. Their patients often have a dizzying mix of chronic and acute health conditions. And in my experience working with certified medical directors, they are more effective at communicating with and coordinating with the interdisciplinary care team. When we collaborate with a certified medical director, we're better at our jobs. That can mean that we're able to reduce the use of psychotropic medications that have very serious side effects. It's a big boon for patients' quality of life, and deprescribing saves money for our healthcare system. So it's no surprise that the statistics show certified medical directors have lower hospitalization rates, better infection control, and higher compliance with CMS quality measures. I'm in support of the transparency and disclosure of medical directors. I think it increases trust and makes it easier for other medical teams like PGS to communicate with medical directors. And I'm also in support of the amendment that Delegate Hill referenced to remove the 2-facility limitation to provide more time for consideration and study. So thank you very much for your consideration and the opportunity to be here.
Thank you for your testimony. And if you can just stay on for our other panelists in case there are questions.
Okay.
And Mr. Kenthetti, if you want to go ahead and unmute and you can begin your testimony.
Oh, can you guys hear me all right?
Yes, we can.
Okay. Good afternoon, Chair Bagnell, Vice Chair Coulson, and Health Committee members. My name is Hemas Kantedi, and I'm a proud student in Howard County, Maryland. I'm currently a sophomore in Howard High School, and I'm here today to voice my support for HB 931, the Nursing Home Medical Director's requirement. When families place loved ones into nursing homes, they are trusting that medical decisions will be made accurately, timely, and with coordination across healthcare teams. Families should never wonder whether clinical decisions will be made responsibility in times of panic. Through volunteering at a nursing home in Columbia, I've seen how quick residents' health statuses change. The importance of having a certified medical director involved with resident care is clear. Additionally, I've also heard from many constituents and their families during my time as a summer intern working in Delegate Hill's office. They share a common concern. Many of the residents are having a hard time understanding who the medical director is, what their qualifications are, and whether medical directors are spread too thin across multiple facilities. Families have expressed how they've had their questions passed across multiple people to finally receive an answer that felt that leaving the conversation still concerned. This lack of uncertainty may not only cause frustration for families, but may also lead to distrust. Consequently, this may cause families less likely to speak up. If families are not willing to speak up, the healthcare providers providing care will feel unsupported and quality improvement initiatives will be difficult to implement. HB 931 addresses this issue with strong solution that increases confidence amongst residents and their families. HB 931 raises the standards for leadership by requiring medical director certification or showing progress towards certification, so families know medical director is given by verified experts. This bill also creates a publicly accessible directory that allows families to easily identify the medical director, their credentials, so residents and their families will know who to contact when issues come up. HB 931 is a cost-effective means for medical directors to improve transparency, increase accountability, and ensure residents receive quality care. For those reasons, I strongly recommend a favorable report on HB 931. Thank you for your time and commitment to improving Maryland's nursing homes. Thank you.
Thank you for your testimony. Great timing. Clearly, you're extremely successful in Delegate Hill's office. Yes, Delegate Hill.
Thank you. First of all, I would like to commend him for that. And I'd like to say, not only is he my ringer, but I had no idea he was going to give testimony till today. And I had no idea what he was going to say. So that is all him, but I'm going to take the credit. Thank you very much.
Excellent. Are there any questions for this panel from our members? Seeing none, thank you very much for your testimony. I also want to thank all of the witnesses on this bill for your patience as we tried to sort of close the loops in our brains as well. We did a lot of subcommittee work right here in the hearing, so thank you. Thank you very much. We are going to conclude this bill hearing on House Bill 931, and we're going to go to your other bill, House Bill 917. This is health insurance retroactive denial of reimbursement. Delegate Hill, you can bring your panel, and you can get started with your testimony whenever you're ready. I have on your panel Dana Kaufman.
All right.
Is she still here?
Dana, okay. Hey, good to see you. Thank you. Yeah, good. Once again, good afternoon, Madam Chair, Madam Vice Chair, members of the Health Committee. My name is Terry Hill, and I'm going to present House Bill 917, Retroactive Denial of Reimbursement. So let me explain what retroactive denial of reimbursement is. It's what we call a clawback. It is when a procedure or a service, a medical service, has been approved and been carried out, been paid for, and then sometime later, the insurer comes back and says, we thought about it a second time and you need to give us the money back. So this committee saw it, for instance, when we dealt with a certain behavioral health payer during COVID, and MDH and the behavioral health group decided because of COVID, we wanted to make sure our behavioral health specialists and providers were getting paid on time, so they came up with a formula to pay them. And then after things settled out, they came back and said, we think we may have overpaid you, and we need you to pay us the money back next week. I mean, that's a little bit of an exaggeration, but you remember how much work we did as a committee, because once you're paid, that money actually goes to your expenses. And when you're then told that there's been an error, and particularly if you recall from those hearings, if there's been an error that you don't think there was an error, so now you're in the position of trying to fight that the money you were paid was actually correctly paid against the power of the folks who are saying we're going to take it back. And while you may have the ability to say, I'm not going to write that check back, they will then say all future payments that we're to give you for future care, we will deduct until we get paid back what we want. So that's kind of how these clawbacks work. And there are lots of legitimate reasons for clawbacks. So under Medicaid, for instance, CMS will pay the state for services that were performed, and then CMS may later come back and decide we shouldn't have paid for something. We may want to disagree with that, but the state is then stuck with having put this money out, and the feds are saying, we're going to take it back, so the state is then in a position of saying, then we have to get it back from the providers as well, whether they agree or not. So that might be a legitimate reason. Other times, a service is carried out that's perfectly legitimate, and then you find out, the insurer finds out afterwards that the person was no longer covered. Maybe they were in the grace period. And so it was provided, and then when the grace period is over, they actually don't renew their insurance. So a service was paid for that they didn't really qualify for because they weren't covered under the insurance company. So there are other reasons where it makes sense. But other things that happen, and I can personally attest to this, where you'll get a letter from an insurer maybe a year and a half, 2 years later that says, we did an audit and we think we paid you too much and we're going to take it back. And the provider's trying to figure out, what do you mean you paid me too much? What was it that you paid me too much for? But the only explanation you get is, we did an audit and we're taking some of the money back, okay? So that's kind of how it works, and what this bill does is it basically defines a couple of things. Number one, when you as an insurer are claiming that you overpaid, you need to give an explanation of what that overpayment was due to. Are you saying that the service was never supposed to be provided? Are you saying that your authorization was authorized in error? Are you saying that in the end, it turned out the person didn't have, let's say as a gross example, that they didn't have a concussion, so you never should have gotten a CAT scan, but at the time that you ordered the CAT scan, you couldn't be sure? I mean, what exactly are the reasons, and what are the processes that the insurer is going through in making these determinations? So we think a provider, just like anyone in any other situation who's suddenly being told that we paid you for something but we want our money back, you would want to know the why. And we think that insurers should actually be responsible for giving that education. Now, in the opposition, you'll hear some pushback about, well, it's going to be burdensome for us to train these people, and if we train them on how the clawbacks are being done and they don't take the training, then they're still, then under this bill, we can't get the money back. Well, that's just not true. And the training can be as simple as, an explanation that's sent out once a year that says these are the policies and processes we follow in determining, retroactively whether things should be paid or not. And if you want to you appeal it, this is what you do. It could be online, where, it's made available. If you want to know how this process works and you want to avoid this in the future, these are the steps that we follow. But it really is just saying these are the rules we're following, and since we're in this game together, you ought to know the rules that you're playing by. And there's also a limit in the look-back period that we put on this bill in terms of what period of time can the insurer look back and determine, wait a minute, maybe we shouldn't have paid you that kind of money. So again, the bill is not to say that clawbacks are not ever appropriate, but it is saying that as a provider who can't take back the service that they've given, we don't get to claw that back, right? That you're entitled to some kind of fair process and knowing what the criteria are, and that there's some limit to how far back people can go before they start taking money back. Because frankly, your business depends on how the cash flows. And if you're spending money that you actually don't have, that creates problems. And with that, I ask for a favorable report. One more thing, amendment. I already spoke to those about the training. Yep, okay, I'm good.
Good afternoon, Madam Chair, Madam Vice Chair, members of the Health Committee. I'm Sarah Trescott, board member of the Licensed Clinical Professional Counselors of Maryland, and this bill does not apply to fraud. Only denials of reimbursement, clawbacks, which adversely affect providers and their clients. Providers often comply with all requirements, yet still go unpaid. Most claims are not appealed, as appeals cost time and money. For example, insurance carriers have demanded between hundreds to over $20,000 in retroactive denials to providers over a multi-year time frame. Providers have to make a decision to address the denial, to keep seeing clients, how to pay their bills, do I take out a line of credit, leading to unnecessary stress and burnout. Providers' calls are not returned after leaving voice messages. They're referred to other departments, no single source to address their concerns. The current law from 1997 is outdated. A potential fix? AI technology can assist insurance carriers develop online training modules to explain documentation requirements up front, perhaps a simple checklist to promote transparency. Carriers can establish a helpline, a single point of contact to help resolve these matters that deal with missing information, incorrect codes, and address corrections. Denials should occur within a defined time period, and minor documentation errors should not justify non-payment. LCPCM requests a favorable report for House Bill 917. When payment systems are not predictable, access to care declines. Not because providers are unwilling to treat clients, but because inconsistent reimbursement threatens sustainable mental health care delivery. Thank you.
Thank you.
Madam Chair, Madam Vice Chair, members of the committee, for the record, again, my name is Dana Kaufman, and I'm here today on behalf of MedChi and the Maryland American College of Emergency Physicians. This bill is one of several bills that you have heard and will be hearing this session, which really just goes to the management and operations of physician offices. Earlier today, I heard testimony that talked about the need for stability and consistency in the market. Well, that's a two-way street. You can't have access to treatment if you don't have physician offices and other healthcare practitioners' offices that can actually maintain paying their staff and keeping the lights on. And that, to me, is what this bill is really about and what several of these bills are about this session. The two most important provisions that I look at when I read this bill was the shortening of the time frame, as well as the ability to have a conversation with the healthcare provider on why the money is being clawed back. As you heard, oftentimes the physician offices are getting notices, but they don't know why, and they don't have an opportunity to address those concerns. And again, as you heard, Maryland's system is complaint-driven, and physician and other healthcare practitioners don't have time to be going through the complaint process. So we need to make sure that that transparency and communication is upfront, and that's what this bill is trying to do. So with that, we urge a favorable vote. Thank you.
Thank you for your testimony. Are there questions from the members for this panel? Delegate Kaufman, followed by Delegate Shalega.
Yes, Delegate Hill, this is a great bill. I have a question, though. You touched on it, but I wanted to give you more of an opportunity to respond to Kaiser's opposition. They say that retrospective denials are key to combating healthcare fraud, and that your bill undermines their ability for fiscal accountability. So I just wanted to give you a chance. What's your response to that?
Thank you very much for the question, Delegate Kaufman. So a couple things. First of all, as was stated by one of the witnesses, this is not about fraud. Fraud is fraud. This is not a denial of payment retroactively because of fraud, okay? So if there's fraud, that's not a retroactive denial, all right? So that's the answer to that part. The second thing is, to the extent that Kaiser and MCOs generally are subject to clawbacks from the federal government, this bill would not affect that either. But when we're not talking about them responding to money that's been taken away from them when they on their own are doing this is what this bill is designed to address. And the bill is also designed to say, again, the notice does not have to be onerous, but you have to be able to define what the rules of the game are that we're playing under. There is I'd like you all to note that the favorable testimony that you have in your file comes from across a range of healthcare providers and other folks. There's also a very brief favorable testimony from a Valerie Farrell in Cecil County, who says, I worked at a company that was created specifically to fight wrongfully denied health insurance claims, and many times that claim was retroactively denied. It is truly a business model to wrongly deny claims. The reason she's saying that is because, and I've spoken to people who've worked in health insurance, I don't want to besmirch any of the folks who are here, but there are insurers who have taken the attitude that if we deny 10, a certain number won't be appealed. And that's a win.
Thank you, Madam Chair.
Thank you. Delegate Shalega.
Thank you, Madam Chair. Thank you for bringing this bill. I thought it was really impactful when you said you can't claw the service back. So as a physician or healthcare provider, you have provided a service under the assumption that you are going to get paid for it, unless you're doing charity care. But, you know, in most cases in your office, you're assuming you're going to get paid for it. So I'm also reading the opposition testimony. So they said prohibiting denials beyond a 3-month window. How flexible are you on the 3-month?
I think we have some flexibility. I mean, we want this to work. We're not trying to put insurers out of business. But again, to your point, I think the thing I also want to emphasize is often these are retroactive denials of already pre-authorized things that we went through the process. This is what we think needs to be done. We get the approval, and then they look back and say, you know what? We probably shouldn't have approved that.
And may I have one follow-up? Thank you. So yeah, it seems like for them to deny something, they'd have to have a rationale. They don't just, we'll deny every 10th claim or, you know, and so perhaps you know why they think it's hard to tell you why they denied it?
I don't know why.
Oh, why?
I don't think they feel any obligation to tell you why, because again, the power that they have is that if you continue to see patients who are covered by them, even if you don't believe it was a just denial, they can debit future payments until they get it back. So you don't really have anything that you can do except to say, I'm going to leave the network where I'm not going to see any more of your patients and I'm not going to pay you back.
Thank you.
Delegate, were you able to speak with the carriers ahead of the hearing? Because I noticed there's very little written testimony other than from Kaiser and from the Managed Care Organization Association.
Had conversations with Kaiser, had some conversations with Ms. Johansson, who felt that if we can make the training a little bit clearer and less onerous, right? That he thought that was workable, but otherwise I have not had conversations with the.
Okay, so, but you are in communication, and maybe there's a favorable with amendments option going forward. So I just appreciate that. I would point out, you know, my concern in the fiscal note is the second page where again, it speaks to that 3-month window, and it speaks to potential expenditures as much as 15 million in the first year. So if we can,
And I believe that again, that has to do with the MCOs, and this bill was not designed to deal with, again, if we're getting money from the feds.
Yeah,
But we'll take a look at that.
So perhaps we can do look at some clarifying language, just so that you know, we're addressing that outstanding fiscal concern. Seeing no other questions, this concludes this panel. We do have an unfavorable panel. We have Michael Johansson, Allison Taylor, Matthew Celentano, and Kimberly Robinson. If you can come to the table and give us your testimony.
Should I go? Okay. Madam Chair, members of the Health Committee, Matt Celentano here today on behalf of the League of Life and Health Insurers in opposition to House Bill 917. Carriers already provide robust documentation and protocols for reimbursement and billing standards that align with the contracts that are agreed upon by both parties. To develop a training program for providers outside of these sophisticated agreements, both entities entered into would be costly. And frankly, we aren't even sure it's possible to operationalize. There is also no direction in the bill on what would satisfy this educational requirement. We have an incredibly difficult time, as we've told this committee over the years, engaging providers to verify contact information, let alone training schedules. League members are also concerned about the changing the timeline requirements in House Bill 917, as we have heard discussed earlier, shortening from 6 to 3 months for carriers to take a look at reimbursement creates a conflict, as providers still have 6 months to even hold a claim. Creating different standards is problematic. And also, I wanted to point out in the fiscal note, it refers not to the MCOs, but to the state health plan. We also have issues with the section of the legislation that requires carriers to have a conversation with the provider to explain the circumstances for modification of reimbursement. Carriers are never opposed to discussing operations with providers, but once again, it's incredibly difficult for us to even get providers on the phone, and to mandate a conversation before a timeline begins could grind payment operations to a halt. This burdensome provision is also confusing. Why would we need this if the carrier has already now trained the providers? It seems designed to allow providers to avoid denials if they can demonstrate anything related to why a requirement should not result in a denial. This sort of circumvents the appeals process, which already exists, for that very reason. So we respectfully request an unfavorable report on House Bill 917. Thank you.
Good afternoon, Madam Chair, members of the committee. Kimberly Robinson on behalf of Care First, Blue Cross Blue Shield, respectfully in opposition to House Bill 917. House Bill 917. a couple of additional thoughts to what Mr. Celentano talked about. You know, one of the things I think that is always so hard when it comes to health insurance legislation in the state is the fact that the experiences of both constituents and of providers is shaped by more places and more carriers and more health payers than what this committee regulates. 17.4%. That's the universe of people that you touch in terms of who in Maryland is under an insured plan. And so as I'm listening to Delegate Hill and her very well-intentioned bill, she said one of the things I was thinking, and I appreciate that she called it out, right? The fact that prior auth is designed to avoid some of this happening. And in fact, in Maryland statute, you cannot go back and undo a prior auth that you previously approved, except under very narrow circumstances. Because the intent in our law is to give that assurance that if we've looked at it and we've said that this is authorized, that we're going to cover it, and it has to be for fraud, waste, and abuse that we're taking it back. It has to be that you deviated from the care plan and it's not what was truly approved in the first place. But if providers are having that experience, it means it's happening in places that your law is not going to touch. And so I think that's part of our challenge with the bill that's in front of us, that it is certainly reacting to experiences of providers, but not necessarily experiences that are currently allowed under the statute in the state of Maryland. And so I think that there's an opportunity to have some conversation about where this is going to reach and where it's not. And then certainly I will just add, Mr. Celentano called out the 3 months. I appreciate the sponsor's testimony that it doesn't touch when it's for fraud, waste, and abuse, because right now, this would say they've got 3 months to file it. We've got 3 months to go back and deny it from the claim or when the service was rendered, but they have 6 months from the service to file it, which my attorneys immediately said fraud, waste, and abuse, because if you wait 3 months and 1 day, you can file it and you can't take it back even if it was fraud. So for that reason, we currently urge an unfavorable report and look forward to talking with the sponsor.
Thank you, Madam Chair. I'm Mike Johansson on behalf of Maryland Physicians Care, MCO. We are a Medicaid-only organization. The fiscal note's interesting because it has this $15 million figure for the potential cost to the state employees' health plan. And it suggests for Medicaid, it's indeterminate, but the size of the Medicaid program is about 8 times the size of the state employees' plan. So even if the state employees plan is half wrong, you're talking about a significant impact to Medicaid. There was also a comment made in the sponsor panel that, you know, somehow the carriers are benefiting themselves. And when you look at what a Medicaid MCO does, we're basically administering a program on behalf of the state. So any of those recoveries that we make eventually get themselves calculated into the entire rate setting system. So if we are recovering money according to our contract under the CMS rules and the Medicaid rules, and if we're doing it appropriately and it's not appealed and rescinded, that type of thing, that benefit of that activity does eventually go back into the Medicaid rate setting system and the state of Maryland. The other thing that's interesting, and they've talked about the 3 months and date of service, the current law is you can go back 6 months from the date of payment, right? So if it was 3 months from date of payment, that's halving the time, which I think leads to significant. But when it's 3 months from date of service, even if someone bills 30 days after the service, you're really only talking 2 months. So I think that timing is also kind of difficult. I will say that every provider that's under contract with MPC should understand and should have the benefit of seeing the guidelines for coding, for payment. That should be part of the contracting process. It is updated regularly in the provider manual that we have, and they should have good information on that. I don't disagree with the goal of that component. So, but at this time, we do oppose the bill as it's written.
Thank you for your testimony. I'm going to open it up for questions from the members, starting with Delegate Kaufman.
Yes, this is for the person that's best to answer. Do you all understand how retroactive denials can create financial hardship for doctors' offices or practices because you do a service, it gets approved, and and you do your payroll, you pay your electric bill and different things like that. So are you at all concerned that if Delegate Hill's bill doesn't pass with a narrow window, whether it be 3 months, 6 months, or whatever the committee decides, that as a result of retroactive denials, many practices and physicians will close up shop because they won't have the money when you come back a year later to pay you back?
Thank you for the question, Delegate Kaufman. We are not in love with the idea of retroactive denials. It is not something that we strive to do. I think that the tension for insurers is that we are also stewards of the premiums that our members pay. And so our goal is to ensure that they have access to care, that we are covering that care, that we have a robust provider network. We do consider our providers to be our partners, and that if all is going well, they are rendering the right service to the right person at the right time, at the right rate, and we are able to provide them that reimbursement that they are entitled to, and that's how it should all work. That's not always the case, and there are circumstances where it is appropriate, in our opinion, for there to be a retroactive taking back of the reimbursement. Again, as I said, that's part of what prior authorizations are designed to try to avoid. Maryland's law is one of the strongest in the country around those prior authorizations for that reason. Ironically, there's also a hostility to prior authorizations in the state, and this committee has barred us from being able to use them in a lot of circumstances in legislation that's been proposed as well. And so again, there's a lot of unfortunate tensions that come in the healthcare system, but retroactive denials are never our goal because we certainly want to keep our providers working and seeing our members.
Can I have a brief follow-up, please? Okay, thank you. Oh, okay, I didn't realize that. Thank you.
Before I take another question, I just wanted to say, I think Allison Taylor left, but.
Ms. Taylor had to go meet with the speaker's staff, sorry.
No, that's fine. I just wanted to make sure that, I had called her.
Yeah.
And Delegate Shalega.
Thank you. I'll be quick because we do. Thank you. Just a comment first, difficult to get providers on the phone, but we hear from providers it's difficult to get the insurance company on the phone. So I think this, is about enhancing communications both ways. Your point about 3 months from service probably should be 3 months from filing if there's going to be some kind of timeline on the retroactive or clawback. But I'll say the biggest complaint that we hear from physicians is the back-end cost of chasing claims. So do you have any suggestions for how we improve that? Because obviously we all want the same thing. Best healthcare, best price, quality healthcare for a reasonable price. And this seems to be something that I think this bill is addressing.
I'll take a shot at that, Delegate Shalega.
I know it was wide open. So.
I agree with what Mr. Johansson said earlier, and I agree with Delegate Hill that we want all the providers to be properly informed about what the responsibilities are and what we expect of both sides in these circumstances. But I think that is because and why there is an extensive contracting process, right? And in the bill, it talks about healthcare providers had to be trained on reimbursement protocols, billing standards, compliance requirements related to the retroactive denial of reimbursement and the denials made. These are already a part of the provider contracts, and the specificity and the details of those parameters are in the provider manuals that they receive upon signing the contract. I'll give you one anecdote, though. This should, I think, give you a little clarity. There is a carrier that in the provider portal has produced videos on every aspect of this. They have thousands of providers. As of like a week ago, they had 6 views. So there is ample opportunity to be educated about what contracts are already out there, but there's not a lot of take-up and exploration of those materials. So it gets back to what we talked about earlier. They say that they contact us a lot. We contact them a lot too. We've had a lot of discussions about provider directories in this committee over the years. And the average carrier is having to do outreach at least 20 times between emails, phone calls, and text messages before they can get a response to verify an address, right? People are busy. I don't know how we alleviate that, but I don't think this bill does anything to actually improve that situation.
Thank you. Technology should help with all that.
Correct, we agree, and that's why we think we need to modernize all technology systems in Maryland.
Thank you.
Seeing no further questions, this does conclude our unfavorable panel. I just got a message that apparently I missed someone for the favorable panel. Dan Doherty, are you here? If you can come and give your testimony.
Thank you, Madam Chair, Madam Vice Chair, and members of the Health Committee. I'm Dan Doherty. I'm here representing the Maryland State Dental Association and the Maryland Society of Oral and Maxillofacial Surgeons. I think a lot of the bill has been covered, and we endorse what the proponents have said. I would just like to emphasize a couple of things. The bill provides for training. I think one of the problems that often occurs is the provider and the insurer are not on the same page when it comes to this. And every insurer is on a different page than the others. So the training is essential, I think, to avoid some of the retroactive denials and to be able to make the conversation that may take place afterwards much more beneficial. I think we also need to realize that the provision of the bill that says when you're looking at services and the retroactive denial, the denial should be after giving consideration of all the circumstances that were prospective. We all know hindsight's 20/20, but you need to be looking at retroactive denials from that point in time when the provider has to make the decisions. So with those remarks, I would urge a favorable report and willing to work with the sponsors and the others to try and make amendments that make it even a better bill.
Thank you, Dan. And just for the record, because you probably said it, but I missed it, who are you here on behalf of today?
Maryland State Dental Association and the Maryland Society of Oral and Maxillofacial Surgeons.
Thank you very much. Are there any questions for this witness? Seeing none, thank you very much for your testimony. This concludes the bill hearing on House Bill 917. We're going to jump to House Bill 637. This is Public Health Recommendations for Immunizations, Screenings, and Preventive Services, Pharmacist Administration, and Required Health Insurance Coverage, the VAX Act. If you want to bring your panel, welcome, Madam Secretary, and you can get started when you're ready.
So thank you. First, I will just note that Secretary Seshmani was hoping to be able to join us, but the timing did not work out. She's still in her budget hearing. Yes. Good afternoon, Chair Bagnall, Vice Chair Cullison, and members of the committee. My name is Hannah Dyer, Deputy Legislative Officer for the Governor. I'm pleased to join you today to discuss House Bill 637, the VAX Act, which will decouple the state's vaccine authority from federal government bodies and instead establish new authority for the Secretary of the Maryland Department of Health to issue official recommendations, excuse me, issue official recommendations for immunizations, screening, and preventive services for Marylanders based on sound science and clinical guidance. The VAX Act directly takes on the recent actions from the Trump administration to reverse decades of standard medical practice and dramatically alter vaccine recommendations for Marylanders, including those that protect our infants and children from avoidable illness. This bill will build on steps taken by the Moore-Miller administration and the Maryland General Assembly to safeguard broad vaccine access. Rather than rely on the political headwinds in Washington for guidance, the Secretary will be able to rely on trusted, independent medical organizations to make decisions based on the best medical evidence. The federal government's rapid shifts and the unnecessary confusion surrounding vaccine policy put public health at risk. Beginning in October 2025 and continuing just last month, the U.S. Department of Health and Human Services has implemented major changes to the government's recommended vaccination schedule for children, decreasing the number of recommended routine vaccines. The CDC no longer recommends routine use of vaccines to protect all children against rotavirus, COVID-19, hepatitis A, hepatitis B, and others. These changes are not based on the sound advice from authoritative medical organizations that the federal government has always relied on in the past. Instead, these decisions have been made following a directive from President Trump after a review process lacking transparency and with a serious lack of substantive evidence. The Moore-Miller administration is not afraid of protecting our people from those who would cause us harm. At a time when the White House is pulling back on sound science that has protected our children for decades, we need to get creative. No state can fill the gap created by President Trump, but we can and will do everything in our power to keep Maryland strong and deliver for our people. In partnership with the Maryland General Assembly, the Moore-Miller administration has taken a number of steps to safeguard broad vaccine access. Last year, to protect Marylanders' access to vaccines, Governor Moore signed House Bill 1315, sponsored by Delegate Gazzoni, to ensure that insurance providers continue to cover the cost of all vaccines as recommended by the Advisory Committee on Immunization Practices as of December 31st, 2024. This legislation protects against the withdrawal of vaccine coverage for a range of illnesses, but was tied to a single point in time. Governor Moore also signed in 2024 House Bill 76, sponsored by Delegate Lopez, to expand vaccination authority for pharmacists, allowing them to administer flu and COVID vaccines without a prescription to anyone 3 years and older. Both of these bills passed out of this committee. In 2025, Maryland joined the bipartisan Northeast Public Health Collaborative and the GovAct Public Health Alliance, partnering with other states and jurisdictions to dispel misinformation, develop recommendations based on scientific evidence, and ensure broad access to quality care and evidence-based guidance. Governor Moore also announced a first-of-its-kind adult vaccine program to expand access to critical immunizations for uninsured and underinsured Marylanders. Administered by the Maryland Department of Health, this program provides recommended vaccines for free to Marylanders aged 19 and older at local health departments across the state. Access to life-saving medicines like vaccines is essential to the health and safety of every Marylander. That's why we will continue to protect Marylanders by ensuring our guidance is driven by proven science and not political headwinds.
Yeah, thank you. Good afternoon, Vice Chair Cullison and members of the committee. For the record, my name is Dr. Meg Sullivan, and I serve as the Deputy Secretary for Public Health Services at the Maryland Department of Health. I'm also a pediatrician with more than 15 years of clinical experience and a mother of 5 school-age children. And in all of these roles, I share the same goals with parents across Maryland: to keep our children, our families, and our communities safe and healthy. Therefore, thank you for the opportunity today to voice my strong support for House Bill 637, the VAX Act. This bill represents a promise we make to Marylanders that decisions about their health will be guided by the highest clinical standards and rigorous science. In the face of uncertainty over the past year, the department has protected access to evidence-based care through standing orders, clinician guidance, public communications, and extensive engagement with stakeholders. This legislation moves Maryland from a reactive posture to a proactive one. It creates a sustainable framework to align our state's recommendations for immunizations, screenings, and preventive services with the trusted clinical guidance of leading medical organizations, the American Academy of Pediatrics, the American Academy of Family Physicians, and the American Colleges of Obstetricians and Gynecologists. The ultimate goal is to prevent debilitating diseases across the lifespan or detect them early when treatment is most effective. This bill keeps the preventive care accessible by requiring regulated private insurance to cover them without cost sharing and maintaining the ability of pharmacists to administer recommended vaccines. I want to underscore that this bill does not create new mandates for individuals. Rather, it preserves deliberative, transparent processes, clear information for patients and their families, clear clinical standards for providers to follow, and the access Marylanders deserve. Like vaccines themselves, these efforts will prevent disease, protect communities, and support long-term health and prosperity across the state. And with that, we respectfully request a favorable vote on this bill. Thank you.
Thank you, Madam Vice Chair, committee members. Marie Grant here in support of this important legislation on behalf of the Maryland Insurance Administration. I am mostly here for any technical questions that might come up about the insurance provisions of the bill, but I just did want to highlight that, again, you all took action in a couple of important pieces of legislation last year to freeze the recommendations of preventive services and immunizations in time, and then to add if there was a consumer benefit. What this bill would do is replace that process with a science-based approach, allows the Secretary of Health another layer to look at the recommendations coming from the federal government based on what key medical societies provide. So with that, we're here in support of the bill. Happy to answer any questions.
Red lights.
I'm reading the testimony, and the one amendment that it looks like a number of people who've weighed in would like to see sunset of January 2029. Would you be amicable to sunsetting the bill, and then you can come back and see how it's working?
So I think we're open to having that conversation. The legislation as it's drafted would allow us to continue to take into consideration the federal recommendations as well. So, willing to continue that conversation, but I think it's a built-in process in the legislation to allow for changes to continue to follow these trusted medical organizations.
Thank you.
So this bill allows or provides that we can continue to look at federal guidance and make decisions based on what we know from evidence-based or what our secretary knows. So who else will the secretary be potentially looking at for that evidence-based data and guidance around these issues?
Yeah, first, I appreciate both the questions, because I think that was something that we talked a lot about. And if you look specifically at the bill text, you can see, and as I mentioned in my testimony, the recommendations would be in accordance with, three specific medical organizations that I named: the American Academy of Pediatrics, American Academy of Family Physicians, and the American Colleges of Obstetricians and Gynecologists. But it also does say in consideration of, and continues to include, specific federal bodies, including the Advisory Committee on the Immunization Practices, including the FDA and the VRPAC, including the Statewide Advisory Committee on Immunizations, as well as other trusted medical organizations, lots of stakeholders that we would continue to engage as we do with every process.
Can you expound just a minute on stakeholders? Who would you be considering in that?
So, I think this would include, just as we talk about other recommendations as well, but stakeholders that are key within our chapters and things that we've already been talking with. So our specific chapters, and I know we have representatives here today from some of those medical organizations, MedChi, the Pharmacy Association, Those are organizations that we would talk to. Parent organizations as well, our education colleagues. I think maybe the reason I'm struggling a tiny bit is because the list is so long, it's hard to name them, but I think it'd be a combination of authoritative medical organizations, both national and then within Maryland, including those that exist, as well as stakeholders across pharmacies, parents, community members, and others.
Great, thank you very much.
Seeing no further questions, thank you very much for your testimony. This concludes this panel. Because we do have a number of favorables and a number of unfavorables, I'm going to kind of go back and forth to be balanced. So I'm going to bring up an unfavorable panel. I have virtually Emily Tarsal, we have, and Sarah Cusack and Catherine Garrett. And do I have Megan Montgomery here as well? You can come to the table. Let me make sure. I'm going to mark myself accordingly. And Ms. Montgomery, you can get started, and then we'll go to our virtual witnesses.
Very good. Thank you, Chair, Vice Chair, and members of the committee. My name is Megan Montgomery. I'm here today representing the Alliance for Science-Based Policy, and I'm very grateful for the time. We have a couple of concerns with this bill, mostly focusing on the liability. The current providers enjoy liability under the 1986 Vaccine Act of the federal government, including for SERVA, which is a shoulder injury related to vaccine administration. It has nothing to do with the safety of the vaccine. It's 100% a provider error. And we are very worried that providers who are going to be giving vaccines that are now recommended by Maryland but fall outside of the federal vaccine approval regime are going to end up in a situation where they are open to liability, right? We can all see it now. I can hear the commercial. Does your shoulder hurt after your flu shot? Call 1-800-FLU-SHOT to see if you are going to get compensation. And what that is going to do to the medical malpractice of our providers is exactly what we saw with the OB crisis of the mid-2010s. It is going to drive providers out of low-income areas, and it is going to hurt the state of Maryland. Do we know how this is going to play out? No, we are in uncharted territory, but this is a very real risk to the people in the state of Maryland. We also have a situation where the AAP, lovely and well-intentioned as they may be, are a private sector group that does not assume any liability for the vaccines they recommend. Neither does the Pharmacy Association or the OBGYN folks. They are private sector businesses that have changed their recommendations as science does. Science moves. We had HPV vaccines that started at 16 to 26, went down to 9 to 11, were only girls. Now they're girls and boys. Now they're up to 65. They were 2 shots, and then there were 3 shots. Now they're 2 shots. They might be 1 shot. We have RSV vaccines that were pulled off the market after they killed babies that were recommended. And so we would like to see this stay as it is now, where this conversation goes on between constituents and this body. Thank you.
Thank you for your testimony. I next have, we have Emily Tarsel? Okay, so let the record reflect Emily Tarsel is not in the waiting room. So we will go to Sarah Cusack. If you want to go ahead and unmute and, oh, Ms. Montgomery, do you want to stay for questions? And just stay till the end of this panel. Sorry.
Good afternoon, Chair Bagnall, Vice Chair Cullison, and committee members. My name is Sarah Cusack, and I'm with the Alliance for Science-Based Policy. While we do understand the good intent of the bill, we do feel that there are implications of this legislation that no one is addressing. I want to clarify what the federal changes do and do not do. The federal changes through the HHS are not getting rid of any vaccines for Marylanders, but they did reclassify some of them. They classified 6 vaccines as now they're calling it shared clinical decision-making, meaning a patient will talk with their doctor. So this is not going to impact Marylanders being able to get vaccines, but it is going to impact liability. So I urge committee members, please read the section on liability, med mal, and healthcare worker shortages in our written testimony. Liability for vaccines has to do with a federal bill. It's the federal 1986 National Childhood Vaccine Injury Act. The act was signed after vaccine makers were inundated with injury and death lawsuits. With the act, Congress took liability from vaccine makers and from vaccine administrators. So in our state, we now have as vaccine administrators, physicians, nurses, pharmacists, and pharmacy technicians. Currently, they cannot be sued if they make a mistake. that the lawsuit has to go through the federal compensation program. Because these vaccines like flu and COVID are being reclassified, if the state of Maryland recommends one thing and it's different than the federal government, those vaccines are not going to have that federal liability protection anymore. So our vaccine administrators in our state will be able to be sued, and that is going to affect med-mal, the rates around that, and that's a huge issue. Thank you.
Thank you for your testimony. We do have Ms. Tarsel in the window now, so if you want to go ahead and unmute and begin your testimony.
Thank you. My website says Chris Tarsel, but I am Emily Tarsel. And I'm a former therapist and a mom, and I oppose HB 637 because based on professional and personal experience, the designated health groups are not worthy of the authority to call the shots. On March 3rd, 2018, I attended a symposium sponsored by the Maryland Department of Health and funded by Merck. The event was titled HPV Vaccination, Doctors Are the Key, and was all about bribes, unethical strategies, and false narratives to increase uptake of the vaccine, and I've included slides from that event. Providers were urged to create competition among staff by tracking and posting the shots they gave and awarding a, quote, cheap bottle of wine to the most aggressive seller. The same for the doctors, but they got handsome bonuses for increasing uptake. The new strategy for increasing uptake was to go from knowing, that is educating, to doing, that is assertively administering the vaccine, saying your child is due for 3 vaccines. Providers were unethically advised to put the HPV vaccine in the middle of the list, vaccinate, and move on. And the messaging was to falsely claim that the HPV vaccine is cancer prevention. However, there's no evidence that the vaccine has prevented even one death from cervical cancer. HPV-related cancers are very low in this country at 0.001% due to Pap screening, and the vaccine was never needed. My 20-year-old daughter and I fell prey to this propaganda. Chris died 18 days after her 3rd Gardasil shot, and after 8 years of litigation, HHS conceded that Chris died from her HPV shots. And when I shared that information at the symposium, the presenter shut me down, said it was anecdotal, and berated me as an anti-vaxxer. Mind you, my daughter was vaccinated. On behalf of my beloved daughter and the thousands of other vaccine injured who were shut down and robbed of fulfilling their lives due to actions by these unworthy, self-serving medical cartels, please oppose HB 637. They have no accountability, and they do not deserve that authority.
Thank you for your testimony, and we are very sorry for your loss. If I can ask you to stay on until our final witness on this panel, in case there are any questions. Ms. Garrett, if you want to go ahead and unmute, and you can begin your testimony.
Good afternoon. Thank you so much for hearing from me today. My name is Catherine Garrett. I am the chair of the Love Maryland PAC here in Maryland, and we have about 3,600 members currently. And many of them are parents of young children, myself included. There's a lot of confusion around what's happening at the federal level and then what's happening here in Maryland. A lot of that confusion is because of this bill. A lot of people are afraid that they will be losing access to vaccinations simply because that's what this bill is saying they're trying to avoid. Meanwhile, Maryland is one of the best states in the whole nation for vaccine rates. 5 years ago, the messaging coming out of the governor's office was that we couldn't question the CDC, that we had to do what the CDC said to do, and now we're saying the exact opposite, and that is just a recipe for distrust for the people of Maryland. It's short-sighted, and quite frankly, potentially harmful without any clear benefit to the public. Having policies like this made outside of the legislature for vaccines are destructive to continuity. Today, we have a Democrat governor, but 2 of our last 4 governors were Republicans. Even within one administration, as we all know, there's significant turnover to any one appointed position. Marylanders deserve to have their elected officials make policy decisions that are this impactful to help ensure a continuity of policy. We've elected our legislators because we trust you, and we would ask that you not outsource this policymaking chosen by the people to do this work. Thank you so much.
Thank you for your testimony. Are there any questions for this panel from the members? Delegate Hutchinson.
Thank you, Madam Chair. My question is for Sarah. I don't see your last name kind of on this. Okay, Cusack. I do see in testimony that MedChi, the Academy of Family Physicians, and the obstetricians and gynecologists are supportive of the bill, but you bring up a lot of issues in terms of med-mal, med-mal lawsuit issues. That's a group that's typically, following that closely, concerned about med-mal. Do you think they're not familiar with what you're talking about, or why would they?
To be honest, these changes are new. I would consider that we are in the in-between. We're in a flux period. It's what I've been reading from legal scholars on this issue is it's going to take for the first lawsuit to happen to really know where this liability is going to land. But per the federal law, if a vaccination is routinely recommended by the CDC and it appears on the childhood schedule, the vaccine administrator is not liable. And what these changes said is that 6 vaccinations, including flu and COVID, will not be routinely recommended. They will be shared clinical decision-making. So many people think that is going to change their liability exemption, but it remains to be seen, to be honest. This is all new.
Thank you very much.
Delegate Hill.
Thank you very much, and I appreciate all of the perspective that this panel brought. Ms. Garrett, I want to say I'm sorry about your daughter's loss, but I have a question because of the information that you said that about Gardasil. Tarsal. Yes, I'm sorry, Ms. Tarsal. Thank you for the correction. I'm reading from the Morbidity and Mortality Weekly Report of the CDC from February 2025, and their data says, and I'm just trying to get the record straight, that between 2008 and 2022, cervical precancer incidents decreased 79%, and higher grade precancer incidents decreased 80% among screened women ages 20 to 24, which is the age group most likely to have received the vaccination. And then they go on to quote a decrease in actual incidence of cervical cancer as well. You said that did I misunderstand that you said that they had not gone down? And if that was your statement, I'd like to know your source. That's all.
Yes, what I had said was that the incidence of HPV-related cancers was 0.001%. That was sourced from the CDC, and there's a slide showing that source, which I've given to you. The incidence of cervical cancer going down, that would be very hard to judge, and the vaccine was never really intended or licensed. It was not approved to they had no proof that it actually reduced cervical cancer because it takes too long to grow. It takes decades, 30, 40 years. So they used a surrogate measure, which was incidence of HPV-related, the incidence of HPVs. Now, HPVs clear on their own 95% of the time. So that was even a spurious measure. But what they may be referring to, and then there's the assumption that reducing the rate of HPV infection is going to reduce the rates of cervical cancer. So it's extrapolated that there's this reduction. Now, there may be a reduction in HPVs, but there was going to be a reduction in HPVs anyway, which was because 95% of the time they clear on their own. So I don't know the specific study you're looking at. I'd be happy to look at it and get you feedback on that, about what they're using to determine the reduced rates of cervical cancer. But and also have a website, and on the website, there's resourced information, documented information about rates of cervical cancer across the world. Now, there are countries where that incidence of that is quite high, like in South Africa. But in America, even at the time the vaccine was introduced, the incidence of cervical cancer in the United States was less than 1%. So it never really was needed. And Pap screening was the way to go because that has reduced the incidence of cervical cancer. But if you want me to respond to the particular study you're mentioning, please forward it to me and I'll get you an answer back on that.
Absolutely. I thank you, and I disagree with your interpretation of the science. Thank you very much.
Delegate Moore.
Thank you, Madam Chair. My question is for Sarah. You turned in a letter of opposition talking about the vaccine injury compensation program. Do you want to elaborate on that?
Yes, so currently, when the federal legislation was created in 1986, we had 3 vaccines. We had the polio vaccine, the diphtheria, tetanus, pertussis vaccine, and the measles, mumps, and rubella vaccine. And if you look in my written testimony, you can see there are many, many, many more vaccines since the vaccine manufacturers had all of their liability removed. Also at that time, only physicians and nurses were administrators. So the federal government took on the liability for any injuries or deaths that occurred for any vaccine that appears on the childhood schedule. And in what I consider a perversion of the law, even if you as an adult go and get a flu shot and you're injured, it still goes through that compensation program because the flu shot appears on the childhood schedule, even though you are not a child. Currently, the federal compensation program has paid out over $5.8 billion. And if you talk to citizens in the state of Maryland, like Emily Tarsell, who have been through the compensation program, they often say it's arduous. It takes a minimum of 8 to 10 years with many appeals. Attorneys do not like it because the maximum awards are capped very low. A deceased loved one receives a maximum award of $250,000. So if this liability is opened up in our state, because if you look to see how many injuries come out of the state of Maryland and go into the compensation program, it's not a lot. But I think that's because it's very difficult to get in. Attorneys don't like it. But if this gets opened up, I think you're going to see a lot more liability activity in our state.
Appreciate it. Thank you. Thank you for.
Seeing no further questions, thank you very much to this panel for your testimony today and for your patience staying with us into the later hours. Now I'm going to turn to a favorable panel. I have Monique Soleil-Burke, Amar Dugirala, Javier Vasquez, and Kevin Lindemood. Sorry. And you can begin your testimony, and my apologies for my butchering of your names.
Right. Good afternoon, Chair Bagnall, Vice Chair Collison, and members of the Health Committee. My name is Javier Vasquez. My testimony today is in my capacity as Secretary of the Maryland State Board of Pharmacy. Although I am also an employed pharmacist at Johns Hopkins, I need to note that the views expressed here do not necessarily reflect the policies or positions of Johns Hopkins University or Johns Hopkins Health System. The Board of Pharmacy proudly supports the VAX Act and efforts to improve vaccine access for Maryland residents based on sound clinical guidance and scientific evidence. Last fall, the Board of Pharmacy worked closely with the Maryland Department of Health to ensure that all Marylanders had access to certain vaccines. The board feels that House Bill 637 is a continuation of the department's efforts to provide access to vaccinations based on that sound clinical guidance, and therefore board is in full support. Moreover, the bill provides much-needed clarity for pharmacists who provide vaccination services to significant numbers of Maryland residents. Since COVID-19 pandemic, the state has increasingly relied on pharmacists to provide immunizations. This bill would ensure that pharmacists can continue to provide these vital services without the risk of ambiguity that may arise from potential deviations from prevailing clinical guidance. For these reasons, the Board of Pharmacy requests a favorable report on HB 637. And I yield the rest of my time. Thank you.
Thank you, Chair Bagnall and Vice Chair Collison. My name is Dr. Amar Dugarala. I'm a board-certified family physician practicing in Poolesville, Maryland for the past 20 years. I currently serve as the president of the Maryland Academy of Family Physicians, and I'm also here testifying on behalf of MedChi, the Maryland State Medical Society. Both organizations strongly support House Bill 637. We believe that vaccine recommendation should be guided by the best available evidence and should prioritize both public health and the individual health of each Marylander. Unfortunately, many of the changes made over the past year by the Federal Advisory Committee on Immunization Practice and the CDC were not driven by new scientific evidence. This has created uncertainty and undermined long-standing evidence-based guidance that physicians rely on to care for our patients. The VAX Act addresses these concerns by aligning Maryland's vaccine recommendations with the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Obstetricians and Gynecologists recommendations, organizations that consistently apply rigorous evidence-based standards to their guidelines. This act will give the Secretary of Health the authority to give guidance not only to healthcare providers, but also confidence to the general public on how to best protect themselves and their families. The recent federal changes have also created uncertainty among physicians and our patients on how this will impact insurance coverage for vaccines. The VAX Act will ensure insurance coverage for these recommended vaccines and give Marylanders their continued options of getting these vaccines either from their physicians' offices or from pharmacists. As a family physician trained in public health who takes care of children and adults in my community who are affected by conditions that are easily preventable by safe and effective vaccines, I respectively ask this committee for a favorable report on House Bill 637. Thank you for your time.
Hi, good afternoon, Chairman Bagnall, Vice Chair Collison, and members of the Health Committee. My name is Monique Swallow Burke. I'm here today on behalf of the state chapter of the American Academy of Pediatrics. I also serve as chair of the statewide Advisory Commission on Immunizations. Most importantly, I'm here today as a general pediatrician and a mom. I won't reiterate what everyone said about the concern and the changes that have been made at the national level that are not based on the rigorous science and data review that the American Academy of Pediatrics have continued to do for over 90 years. The AAP has put forth immunization recommendations, as I said, for over 95 years. It wasn't until the late 90s where the ACAP became available, where they started really working with the CDC. And they have been congruent. They've been the same up until recently, where the AAP has deviated and felt it was very important to come forth and reemphasize that the AAP has been putting forth these recommendations for almost a century, basing them on science, and will change recommendations based on science. I also want to just say it's been important for me. I'm a general pediatrician. I spend the day in my office talking to families. Last week, I had a patient of mine that come in. He has complex congenital heart disease. His parents actually immigrated from West Africa so that he could get care for his congenital heart disease. This child is an extremely high-risk patient. He's had his flu vaccine for 13 years. This year, we talked about the flu vaccine, and I do want to reiterate that shared clinical decision-making is something that every physician and provider partakes in every single day. This family finally, for the first time ever, was like, I'm not sure about the flu shot. I'm very worried. I keep hearing things. I keep having all these questions and concerns. Is this different than it's always been, Dr. Burke? And no, we have a good conversation. It's not different. It's the same as it's always been. There's no new data. And that patient is very important that family feel comfortable because that flu vaccination could truly save his life. So on behalf of the pediatricians in the state of Maryland, moms in my area and moms across the state, we would urge you to vote favorably for this bill to support the continued administration of vaccines for our children.
Madam Chair, Madam Vice Chair, members of the committee, I'm Kevin Lindemood, the CEO of Healthcare for the Homeless. We're Maryland's leading provider of integrated healthcare and supportive housing for people experiencing homelessness, serving about 11,500 people last year at clinic sites in Baltimore City and Baltimore County, through a mobile clinic, and on the streets. We're here in very strong support of the VAX Act and applaud the administration's leadership to introduce it. Throughout our 40-year history, we have routinely relied upon the CDC and other federal bodies for guidance on life-saving vaccines and for recommendations on screenings and preventive services, which are so important, particularly for vulnerable populations. They are essential tools in our work. We relied on this guidance during flu season. We relied on it during the COVID pandemic, which took a particular toll, as you all know, on vulnerable populations. We rely on it in our work with children and in our OB clinic. We rely on this guidance to screen for preventable illnesses and cancers. Our providers see what happens when people don't get access to routine screenings. As the sources that we have relied upon depart increasingly from the scientific consensus, we applaud states like Maryland for stepping up to fill that gap. Because of the success of vaccines, I would add, most of our providers have never seen some of the things we're now seeing. Mumps, for example, 4 cases all of last year, 26 cases so far this year. It might be 27 now. Defer to my colleagues. And we're concerned about what may happen, as we have seen in other states, as more Marylanders, as we lose herd immunity, which really benefits all of us. And so we strongly support the act and look forward to its swift passage. We share the concern that this is distressing, and we applaud people for standing up to relieve that distress.
Thank you very much for your testimony. I'm going to open it up for questions from the members. Delegate Hutchinson.
Thank you, Madam Chair. My question is for the doctor in the lab coat. I appreciate you coming. It's not every day that we have someone from MedChi that's in a white lab coat at the table, which means there's some importance to this. So I asked the previous witness the concerns about medical malpractice that she had brought up. I saw that every physician group is favorable of this. Any concerns about that?
Yeah, I'm actually glad you brought that up. So I actually reached out. So I'm president of the Maryland Academy of Family Physicians. We're a state chapter of the American Academy of Family Physicians. I actually reached out to our American Academy because they're much more familiar with the vaccine injury compensation fund. What I was told is, I'm quoting them, to be covered under the vaccine injury prevention program, a vaccine has to be A, subject to the vaccine excise tax, which Congress controls, and B, be listed in the vaccine injury tables, which the HHS secretary controls. So those have not changed. So from my understanding and the understanding of the American Academy of Family Physicians, is that the compensation fund would still be appropriately covering vaccines and vaccine injuries. So again, I can take it back to our academy and get you more information on that, but that is my understanding. So we as physician groups are not concerned about liability protection.
Great, I appreciate that. What you just read, could you send that to the committee, please?
I can.
Thank you.
Seeing no further questions, thank you very much for your testimony today. We are going to go to an unfavorable panel. I have Valerie Borick, and then virtually Jenna Butler and Jill Capper. And I believe that is all of our unfavorables. I just want to make sure I haven't missed anyone. All right, and Ms. Borick, if you want to start your testimony. Sure.
Okay, hi, my name is Valerie Farrell. Actually, I got married. I guess I need to update my MGA. So I'm from Cecil County.
And congratulate.
Oh, thank you. I'm from Cecil. I'm a mom. I'm an attorney and an author, specializes in public health policy. And I'm looking at this bill specifically at the very beginning of it, where we're talking about, and even in the press release from the governor, we were told that this would give authority to the Department of Health to follow these organizations that have been named AAP, ACOG, AAFP, but this is totally unnecessary because they're already following it. And so I think that on their website, and you'll see in my written testimony, just page after page, there's screenshots, there's standing orders where the Department of Health is already choosing to follow this organization. And the concern that I have here with this bill and this language specifically is that the word shall is used. And we all know this is a legal term of art. So when we say shall in a piece of legislation, we are mandating or taking away the choice of the Department of Health. So we're, with this legislation, even though the next section says that the department can take into consideration other guidance. When we say shall, that means that we're tying their hands, and that's very concerning. And then specifically with respect to these organizations, we've heard a bit here and there about another section of this bill where we're making sure that we still have access through insurance, but unfortunately we had tied this to a point in time with the immunization schedule from 2024. We're at another point in time where right now, some Marylanders, the governor doesn't like what the federal government has done with respect to health policy, which by the way is guidance. The federal government, the CDC's recommendations are that. They're guidance, they're recommendations. They're not actually Maryland law. We make the Maryland law and we need to keep that here enshrined. And I really do think that this is an unconstitutional delegation of power if we were to say that our Department of Health needs to be tied to organizations. And also in my written testimony, there's information about how these organizations also are subject to, different, they're human, they have their corporate sponsors, they have all of the people or all of the vaccines that are made that they're recommending, they're also getting money from.
Thank you for your testimony. And if you want to just stay while we finish this panel in case there are any questions. Thank you so much. If I can ask Ms. Butler, if you want to go ahead and unmute and begin your testimony.
Yes, hi, thank you. Thank you, Chair, Vice Chair, committee members for your time today. My name is Jenna Butler and I'm from outside Annapolis. I first just wanted to say, kind of to reiterate, watching the testimony today, it seems like this is coming up a lot. This bill is really, really unnecessary. Nationally and in this committee, the insurance access has already been assured. Access, broadly has been assured in Maryland. I think the committee here and the administration has done a good job on that. But as a parent, talking to parents, I can tell you that this does nothing to restore confidence because it is making it very, very confusing for parents. The CDC changes really were so minimal. And so this feels, like an overreaction almost. It was just moving categories around and no one's losing access to any vaccinations. The parents, they don't understand this overreaction, I feel like, the people I've talked to. It feels political and not in their best interest. And the most concerning thing to me about this bill is we're handing over any role to these organizations that have so many pharmaceutical sponsors. There's so much money involved here. And again, as a parent surrounded by parents, I can tell you that our pediatricians are not recommending the COVID vaccine at 6 months old. And that is something that the AAP has not budged on. So I do question why the AAP is so out of touch with reality on that recommendation. And I really see an opportunity here for Maryland to lead and avoid this potentially dangerous overcorrection. And it would be a shame to burn so much trust and add more confusion to parents. Thank you so much.
Thank you for your testimony. Ms. Capper, if you want to go ahead and unmute and you can begin your testimony.
Good afternoon. My name is Jill Capper. I'm here requesting because this bill shifts health policy authority from elected lawmakers to unelected officials. The authoritative medical organizations that will be handed over this authority cannot be trusted. These organizations, these trade organizations who would be given the power have proven to be biased towards protecting their health care provider members and their organizations as they receive substantial pharmaceutical funding versus protecting and improving the health of Maryland constituents. No threat to vaccine access even exists even with the varying and changing recommendations across the various bodies, including the CDC, and the science that the AAP chooses has proven to be selectively biased. CHD, a nonprofit advocating for our children's health, and other plaintiffs have recently filed a racketeering lawsuit against the AAP of similar nature to the tobacco industry case of the 1990s. The lawsuit accuses AAP of conflicts of interest and racketeering over the last few decades for receiving major funding from pharma and implementing schemes to incentivize high immunization rates while making repeated false claims about vaccine safety. The ACOG continues to recommend COVID vaccines to pregnant women, contrary to the long-held golden rule of protecting pregnant women and their unborn children. under the precautionary principle. The ACOG and AAP are outliners compared to other organizations around the world, as many utilize targeted recommendations or have even removed COVID vaccine recommendations for pregnant women and children. This bill's directive to follow the generally accepted consensus within the scientific community is subjective and biased. So-called consensus is too often manipulated by ways of threats to medical license or livelihoods of medical researchers and professionals who have dared to question the consensus science or narrative. These trade organizations assert that their recommendations are grounded in proven science, but they consistently reject any reasonable challenge to that science, which is inherently unscientific. Policies with broad impact on healthcare access and personal choice should be debated openly by the legislator. Maryland families deserve legislative oversight and transparency for decisions affecting healthcare. These trade organizations will not put Marylanders first, needs first. Therefore, I again request that you oppose HB 0637. Thank you.
Thank you very much for your testimony. Are there any questions for this panel from the members? Seeing none, thank you all very much for your testimony today. We do have one more panel on this bill. I have Gabrielle Robinson, Monique Ashton virtually, and Aaliyah Horton. So we'll start with our in-person witnesses and then go to our virtual. You can start your testimony when you're ready.
All right. Good afternoon, members of the delegation. My name is Gabrielle Robinson. I am here on behalf of the Maryland Citizens Health Initiative as a BSW level intern in favor of this bill. I would first like to say thank you to Committee Chair Bagnall, Vice Chair Collison, and members of the Health Committee for allowing me to speak today. The Maryland Citizens Health Initiative strives to expand affordable and accessible health care to all Marylanders, which includes preventative care. I am here not only on behalf of my agency, but also as a student with immunocompromised family members and family members who serve in the healthcare system as health providers. It is extremely important for the public to be informed of vaccinations and the science behind the recommendations. This bill will restore trust within the state for health recommendations, as so many citizens have reported losing faith in the CDC to provide these accurate vaccine and healthcare recommendations during this time. As it has been proven time and time again, vaccinations save lives, especially of our immunocompromised family and friends who depend on us to have accurate recommendations as well as expanded coverage and access to vaccines that are recommended. This bill does not mandate people to get vaccinated, but encourages the public to listen to well-researched recommendations if they choose to. So I urge you to please give House Bill 637 a favorable report. Thank you.
Hi, good afternoon. My name is Aaliyah Horton. I am the Executive Director of the Maryland Pharmacists Association and also representing the Maryland Pharmacy Coalition today. And we urge a favorable report on House Bill 637. I want to start out by first thanking Delegate Guzzoni for working with us to pass House Bill 1315 in last session. And I want to emphasize that because that bill passed, Maryland had minimal impact on the changes that occurred at the federal level because we took steps to protect vaccine access in the state. There were still some hiccups in the fall that the Department of Health and the governor worked through to ensure that access to vaccines were fully available via pharmacy services. And as you are well aware, the vast majority of people get their vaccinations via pharmacists. So I want to put that out there. And so we're really happy to work with the department on the concerns that we had about recommendations being rooted in science. And so I won't go through all the testimony that everyone else has said. So we're happy, we want to support this bill. The other thing that I want to mention is to provide some additional clarification on the vaccine liability coverage. So as the doctor mentioned, as long as the vaccines and the injury are listed in the vaccine injury table and have that excise tax applied, it's covered. So whether Maryland makes a recommendation or even the CDC makes a recommendation on changes in the vaccine schedule, changes recommendations, or even adds that shared decision-making language, it is based in HHS rulemaking process. So it has to go through a federal rulemaking process to change anything in that injury table. And that is a lengthy process. If any of you all have ever worked on federal regulations, it is difficult. And so as long as, about 9 seconds, all the routine childhood vaccines are there, and many of the adult vaccines, including flu, pneumococcal, hepatitis A, B, HPV, and all the others are also listed. So I wanted to just provide that clarification. Thank you.
Do we have Monique Ashton virtually?
Good afternoon. Yes, this is Mayor Monique Ashton from the City of Rockville. I want to thank Chair Bagnall and the members of the House Health Committee for this opportunity. We also want to thank House Speaker Benya Melnick and the colleagues for sponsoring this important legislation. I wanted to share some perspectives from the City of Rockville. HB 637 aligns with our priority to protect the health and safety of residents in our community. We strongly support vaccines as they remain one of the most powerful public health tools used to protect against severe illness. Recent shifts in the federal processes away from evidence-based guidance grounded in rigorous science are very concerning, and we support this legislation for the following reasons. It establishes authority for the Secretary to issue official recommendations and also support preventative services. We also really support working with the authoritative medical organizations to help provide those recommendations. We also think it's important to assure access. Maryland health insurers need to be able to provide access to these vaccines, and this would allow us to make sure that there are not situations where residents would not be covered. I wanted to share two local perspectives. We are hearing from some residents who had more difficulty getting access to vaccines, especially at the pharmacy level this past year. We also have heard from some of the companies who are working on investments in life science that their world has been a little bit shaky because they want to make investments to create life-saving vaccines, but without the authority that there's a pathway through coverage, that they may not be able to do that. So I wanted to share those two perspectives on how it helps patients, but how it also would support innovations in healthcare that we need. We applaud the Moore administration for protecting our communities by quickly adjusting the state vaccine policy in response to these federal shifts. And for these reasons, we urge the committee to provide SB 385 a positive, HB 637 to provide a positive report. Thank you.
Thank you for your testimony, and thank you for being with us, Mayor Ashton. I'm going to open it up to questions from the body, but very quickly, I just wanted to circle back and let our committee and the public know that there was a study released 3 days ago by the American Cancer Society on the efficacy of the HPV vaccine that demonstrated a 27% decline in cervical cancer. And there's a lot more in the study, but it's very recent. It was released February 23rd, 2026. I'm happy to share it with the committee. But I just wanted to make sure that the record was clear, and that they said notably the significant correlation between higher vaccination rates and greater progress across states was consistent with what they had anticipated based on the proven effectiveness of the HPV vaccine. With that, I will open it up for questions from Madam Vice Chair Cullison.
Thank you, Madam Chair, and thank you all for staying. And the people behind you, thank you all for staying today. We really appreciate it. Aaliyah, I wanted to give you a chance because I think you were kind of rushing through the malpractice. So I wanted to give you a chance to say a little bit more and expound on that, and so that we clearly understand that what I think I'm understanding, which is there's protection. That protection still exists against malpractice.
Yes, there's the protection via the Vaccine Injury Compensation Program. And there is a table essentially that lists the vaccines and then injuries. And as long as the injuries are listed there, then the injuries and the vaccine are listed in this table, they're covered. And the vaccine has to have this excise tax. It goes into a lot of detail. It was a quick quick learning experience over the last couple of weeks. But the vaccines that are covered include, as I mentioned, the routine childhood vaccinations, MMR, DTaP, polio, and more, flu, pneumococcal, hepatitis AB, HPV, and others. And so if it's there, it's there. And the process, and what was clarified to me is that even if the CDC makes changes, Maryland makes changes, the table doesn't change. And in order for it to change, you have to go through an HHS rulemaking process. And that's pretty substantial. And so I think with the, well, let me not pontificate. I'll leave it at that.
Thank you very much. I appreciate that.
Are there any further questions for this panel? Seeing none, thank you very much for your testimony today. This does conclude the hearing on House Bill 637. We're now going to pivot to our last two bills of the day by our wonderful Madam Vice Chair, starting with House Bill 1112, which is Health Insurance Coverage Protection Commission Study on Individual and Group Health Insurance Market Stability. I can tell it's getting late because I'm struggling to talk. So, Madam Vice Chair, if you want to go ahead and head to the table and bring your panel, and you can begin your testimony whenever you're ready.
For 112. Okay. Thank you, Madam Chair, and thank you, committee, for your endurance today. I really appreciate it. I'm wondering if Robin Elliott is here.
She was just, yep, there she is. I have on your sponsor panel, Robin Elliott, Dana Kaufman, and Marie Grant.
And Marie Grant, right. So as they were, pardon? No, this is not your bill. Yeah. Different bill. Different bill. That's the next one, sorry. Thank you all very much for the opportunity to speak to you today on House Bill 1112. I am Bonnie Carlson, representing District 19 in Montgomery County. This bill takes advantage of a commission that we already have in place to address ways to support our current healthcare coverage models. The Maryland Health Insurance Coverage Protection Commission, and I have to remind myself often of all of the words, was established by the passage of House Bill 718 in 2025. That bill identified a comprehensive set of charges to monitor, assess, and make recommendations regarding related to the federal changes in the Affordable Care Act, the Mental Health Parity Act, and Medicaid programs, the Maryland Children's Health Program, Medicare, and the Maryland All-Payer Model. So the commission already has a pretty big charge because it's looking at all of those things. The commission has not actually begun its work yet. It's been a struggle to get everyone appointed, but I am told that we are very close, and I am hopeful that it will meet early in May for its orientation meetings. In the meantime, we've already seen changes at the federal level that threaten access to care for Maryland residents. These include the changes in our all-payer model for hospitals with the withdrawal of Medicare pass-through funds beginning in 2028. In addition, with H.R. 1, it shifts the administrative cost of Medicaid to the states and eliminates options for collecting funds to cover state Medicare share in the short term. The leadership of our Health Benefit Exchange and the Department of Health report their monitoring changes at the federal level, and every day, they say to me, and in the last 40-some days we've been here, I hear this, they anticipate more significant impact over time. In October of 2025, the then chair, now speaker, of this committee convened a group of delegates, current and past leaders in the healthcare arena here in Maryland for the purpose of brainstorming policy and legislative options for potentially a public option or other healthcare system transformations to address rising uninsurance rates and coverage instability in Maryland. The outcome of that discussion was that a public option may not be the most beneficial for Maryland because our all-payer hospital rate system compresses the pricing gap between Medicaid and commercial rates. So we wouldn't see as much benefit from as other states would. In states like Washington, Colorado, New Mexico, they don't have the all-payer model. They can implement a public option and see a 25% differential. In Maryland, it's about 7%. So that really limits our potential premium reductions to perhaps 10 to 15%. Our reinsurance program, which we can all be really proud of, has achieved some really significant rate relief, but this fund won't last forever. And we are always, frequently using the fund. So in response to the public option question, there was some discussion around an actuarial analysis comparing Medicaid and commercial rates to estimate premium savings. But when you see the fiscal note on this bill, it speaks specifically to that study. I'm willing to discuss that study as we discuss this bill. We could explore regulatory exemptions to allow Medicaid MCOs to sell on the individual market without meeting full insurer capital requirements. We came up with a lot of different things that we as a state should be examining, and they're contained in this bill. Now, I'm gonna do a little forewarning here. There will be another bill next week that is also an outcome of that meeting. This bill, what's represented in this bill are the things that we see are more short-term kinds of potential options that we can look at and in addressing our immediate concerns. But the bill we'll be talking about next week is going to be a longer-term, futuristic look at Maryland. So what we did was we took all of the things, all of the possibilities that came out of that. I think it was about a 2-hour meeting with a lot of smart people in the room. I think they're sitting here, at least some of them are, and said, what are some things that this commission we already have can start looking at? So again, that's what you see in this bill. Now, in some discussions with some folks as we've talked during this session, we see that there's a potential to add 1 or 2 things. One of the things that I know I want to add is, and we'll be accepting as a friendly amendment to the bill, is a charge to study the adoption, to study what the impact of an adoption of converting our Medicaid program from MCOs to a fee-for-service model. Again, that's just another thing that we need to look at, and Progressive Maryland is very interested in that and as a possibility to support some of our folks who are needing that Medicaid coverage. The commission the composition of the commission is extensive. This current commission that will start working in May, if I have my way, is very extensive, very comprehensive, includes all aspects of healthcare, and I'm confident that they can take a look at these additional pieces of their charge, make some recommendations. There may be things that they can come back with in January of 2027. They may make recommendations about how to do this, to look at these things further, but I'm confident that they have the capacity to take a look at these charges as well as the ones that are already there. So with that, I'm asking that you give us a favorable report on this bill, and I will turn it over to Robin.
Marie.
Okay. Oh, Marie, over to Marie. Excuse me, over to the commissioner.
Thank you so much, Madam Chair, committee members, Marie Grant, on behalf of the Maryland Insurance Administration. In the interest of time, let me just say we're supportive of this bill. There's a lot of different looks in here. I think we've talked to you in different settings over the past year or so about how changes at the federal level are really going to necessitate taking a hard look at how we finance healthcare. I think all of the things are important looks for us to consider. That doesn't mean we have to do them, but it means that they're all worthy of consideration. And so with that, urge a favorable report.
Good afternoon, Robin Elliott, here on behalf of many clients, some of whom are here for Delegate Cullison's last bill, and many safety net clients, very much in support of the bill. These clients include the nurse midwives, the physician assistants, the school-based health centers, the school health nurses, the Maryland Dental Action Coalition, and a group of federally qualified health centers called Maryland Community Health System. Just want to highlight one thing this bill does that we find particularly important, and that is looking at whether or not there should be additional support for our federally qualified health centers. They're in many communities across the state. They are seeing significant increases in the number of people who are uninsured, and it's not sustainable in the long run. So really appreciate Delegate Cullison's inclusion of that in this legislation, and we ask for a favorable report.
Madam Chair, members of the committee, for the record, I'm Dana Kaufman. I'm here on behalf of MedChi, and I'm just going to say me too.
We love that testimony. Are there questions from the members for this panel? Delegate Tavares.
Thank you, Madam Chair, and you know I'm very excited about this bill. But per the 2025 white paper from the Physicians for a National Health Program, how much do they say that would be saved if we were to implement this particular model here within Maryland? Annual savings?
I'm not sure which model you're referring to, because what we're doing is adding to the charge.
For service management model for Medicaid.
Okay, I'm sorry, Delegate, I don't have that information. Do you have it?
I believe it's $521 million per year.
So, and that's something that if this bill passes, we would be looking at.
That's right. And I believe that a similar study, that maybe some of the other panelists that come up to verify, when Connecticut did it, they saved over the last 12 years, they saved approximately $4 billion in doing this as well. So this is real money that we can put back in the coffers to help more people. Thank you.
Thank you.
Is that right?
Sounds like something we should look at, Delegate.
Seeing no other questions, I'll just dovetail a little bit. That would be the kind of study and financial modeling that the commission would be able to look at, wouldn't have to recreate. Is that correct?
Correct.
Yes. Thank you very much. Thank you very much for your testimony. We do have several favorable with amendments, and I think you spoke to the fact that we're still looking at amendments.
Yes.
So if I could get Erica Puentes, Alacrita Olson, Yvette Delph, Stephanie Clapper, and Emily Leonard. You can come to the table, begin your testimony when you're ready.
Hi, I'm Stephanie Clapper, Deputy Director at Maryland Healthcare for All, here to submit supportive testimony with a proposed amendment. The Maryland Healthcare for All Coalition brings together hundreds of faith, business, labor, community, and healthcare organizations from across the state working towards quality, affordable healthcare for all Marylanders. We are very grateful that the Health Insurance Coverage Protection Commission will hopefully convene soon in order to respond to federal attacks on Maryland's access to health coverage. And I want to thank your committee for your leadership role in enacting several successful premium assistance programs in the past to help Marylanders be able to afford health coverage in the individual market. This includes the very successful Young Adult Subsidy Program, which has been helping young adults afford their health coverage. Bringing young, healthy adults into the individual market is good for everybody because they tend to be healthier. That stabilizes premiums for everyone else. And young adults have also been able to get better quality coverage with lower cost sharing. And that program's been improving health equity by race and ethnicity. And then last year, the state-based health insurance subsidies program was created. It is currently helping Marylanders whose enhanced federal tax credits have expired to be able to afford their coverage in the individual market. And both of these programs are facing challenges in the coming years, and many Marylanders whose enhanced APTCs were terminated have had to drop their coverage or downgrade to plans with lower level metals. And so we're very supportive of this bill and ask that you consider an amendment to add to this study identifying ways to sustain and increase premium assistance in the individual market. So we urge you to do a favorable report with this amendment, and thank you for your consideration.
Good afternoon, Chair Bagnell and members of the Health Committee. My name is Erika Puentes. I'm delivering this testimony on behalf of myself as a Marylander. I'm in strong support of HB 1112 with the amendment presented by Vice Chair Cullison to establish a work group to understand the benefits of transitioning away from the managed care model towards a fee-for-service model. Not only will this help Maryland save a tremendous amount of money per year, but it will also help Marylanders like myself who have struggled with MCOs meddling with my medical care. A few years ago, I enrolled in Medicaid. The enrollment process was incredibly daunting. I ended up choosing Priority Partners because it is affiliated with Johns Hopkins, where I received my medical care. But Priority Partners denied my Johns Hopkins doctor's request for an X-ray, which means I have not received adequate care for an issue that continues to disrupt my life. And over a year after receiving PT for an injury, I received retroactive denials and ended up with thousands of dollars of medical bills that I thought were long covered. Moving away from MCOs would mean a lot to Marylanders like myself, so that we don't have MCOs denying our care and leaving us in medical debt. The enrollment process for Medicaid through MCOs was incredibly complicated too. As a daughter of immigrants, I have been helping my family fill out paperwork since I was in elementary school. And even with this experience, with age and with my high level of education, I still found it difficult to navigate the MCO enrollment process for myself. Connecticut made the switch to a fee-for-service model. When I looked up their enrollment process, it was as simple as enrolling into a plan based on your age group. I can say with absolute certainty that not only would this be easier for me to navigate the Medicaid enrollment process as an adult, but this process would have been much easier to handle as a 7-year-old kid filling out paperwork for my family. Maryland could save a significant amount of money from this switch. Patients would benefit from MCOs not denying and disrupting our care. And the ease and simplicity of enrollment can help so many people like myself. For these reasons, I support HB 1112 with the Vice Chair's amendments.
Good afternoon, Chair Bagnell, Vice Chair Cullison, and members of the committee. My name is Yvette Delph, and I am a retired physician and a volunteer leader with Progressive Maryland, living in Silver Spring, District 19, and I respectfully request your support of HB 1112 with the amendment from Delegate Cullison, which would instruct the Maryland Medical Advisory Committee to establish a work group to study the adoption of a direct payment system or fee-for-service model for all Medicare services and report on its findings by January 1st, 2027. In the face of looming federal cuts, funding cuts that you face, and changes to Medicaid enrollment requirements, Maryland needs urgent solutions. A recent report from Physicians for a National Health Program estimates that based on 2023 expenditures, establishing a fee-for-service model for all Medicaid services would save Maryland up to $521 million every year. According to the Maryland Department of Health and the 9 Medicaid managed care organizations, the 9 Medicaid managed care organizations received more than $1 billion in administrative expenses and profits in 2023. That's 13 cents on every dollar they received. Maryland could administer Medicaid directly for 3 cents on the dollar. Since Connecticut implemented such a system in 2012, it saved $4 billion. The direct payment model would be a win-win-win solution for Medicaid patients, providers, and the state. It would help avoid cuts to Medicaid services and minimize increases in the number of residents without health insurance. As in Connecticut, with the direct payment system, we could see less bureaucratic complexity and paperwork, fewer denials of care, and fewer delays in provider payments. At least 7 other states are actively working on similar legislation, and so I urge you to give a favorable report on HB 1112 with an amendment. Thank you very much for your attention.
Good afternoon, Madam Chair and members of the committee. My name is Ellen Creda Olson, and I'm a preventive medicine physician and a member of Physicians for a National Health Program. I am testifying in support of HB 1112 with the sponsor's amendment. In light of federal Medicaid cuts, the sponsor amendment to this bill is an opportunity to explore a solution for savings, removing managed care organizations. MCOs are supposed to assume the financial risk for Medicaid costs, reduce spending, and improve care coordination. The reality is far different. The state still covers most of the sickest beneficiaries that MCOs leave out, while the MCOs control their share of the risk by wasting money on administrative hurdles for patients and physicians alike. From prior authorizations to appealing denials, physicians spend more time fighting the system than we do with our patients. The narrow networks created by MCOs also make it difficult to coordinate care and get patients to specialists. Recently, a colleague shared the distress she was experiencing from getting a pediatric patient on Medicaid to a pediatric urologist, as there was one in their network, which meant a 6-month wait. The distress of dealing with MCOs compounds day in and day out, leading many physicians and other healthcare workers to leave the field. When Connecticut removed MCOs from Medicaid, they saw increased physician participation in the Medicaid program, and recently a 97% satisfaction rate from physicians. This, plus the eradication of narrow networks, meant improved access to care for beneficiaries and better health outcomes, with a decline in ER visits and hospitalizations and an increase in early cancer detection rates and cancer survival rates. Connecticut utilizes administrative service organizations to administer their Medicaid, and with this work group, we could examine how Maryland can best administer a Medicaid fee-for-service program that will reduce practitioner administrative burden and increase access for patients. In addition, Maryland has been a champion of enhanced primary care delivery with our TCOC model. Removing MCOs provides us with an opportunity to improve care coordination for our Medicaid population as well. Therefore, I urge the Health Committee to issue a favorable report on HB 1112 with the sponsor amendment. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. My name is Emily Leonard, and I strongly support HB 1112 with an amendment the sponsor is offering, which calls for a study into the transition away from Maryland Medicaid's current managed care model towards a fee-for-service approach. At $521 million in potential savings per year, the fiscal implications of this reform are staggering, but it goes beyond that. As a former health policy analyst in Maryland Medicaid, I saw the amount of coordination it takes to work across 9 companies. They are given control of billions in state dollars. They retain a chunk of that money at a time when the state needs to retain funding, with $1 trillion in federal cuts coming over the next decade. Currently, the state must coordinate with these 9 MCOs to implement policy, limiting the state's agility when it comes to setting health priorities and responding to situations like public health crises. Through the MCO model, the 9 MCOs receive financial incentives if patient outcomes improve. Through the fee-for-service model in Connecticut, these incentives go directly to providers when they coordinate and improve care. They can then grow their practices. We need more providers in the state, and we need to make it easier for them to take Medicaid patients. This reform would allow Maryland to regain control over patient data. We are proposing one clean data flow from providers to the state instead of moving it through multiple entities. Federal audits have found that states cannot confirm MCO encounter data as easily. Data may be delayed, it could change, or it could never be submitted. What we are proposing eliminates that issue. Connecticut's reform has withstood the test of time. Over a decade later, they have a 14% lower per enrollee spend than their peers in the Northeast. I respectfully ask you to support this amendment to HB 1112 and let the conversation begin. Let's explore the potential to save money. Let's allow public servants and providers to do what they are trained to do, improve the health of Marylanders. Thank you.
Thank you for your testimony today. Are there any questions from the members for this panel? Seeing none, thank you very much for your testimony. This concludes this panel and concludes the bill hearing on House Bill 1112. And we are now going to move to our final bill of the day, which is House Bill 1093. This is, excuse me, Health Insurance Provider Panels Requirements. Vice Chair Cullison, if you want to come to the table. I have 7 members of your sponsor panel, so do you want to do like 4 and 3?
That sounds
And then we'll
great.
open it up for questions? Okay.
Perfect. If everyone's still here, let's see. Tammy, what's looking good? Yes, you are. Hi. Some old friends here. Good evening again, friends on the Health Committee, Madam Chair. I am going to start off this bill hearing with saying it's not quite fully cooked. It's probably about 75% cooked, I think, but I'm going to just put it up front that I am trying to work with all of the advocates from the different perspectives to see if we can get it to that final bake period. This bill, 1093, the underlying purpose is to support healthcare providers in meeting the needs of their communities. This is something we work on all the time, and we're looking at it across the state, from Western Maryland all the way to the Eastern Shore. And, you know, as one of our previous panels just said, we can't increase the number of healthcare providers overnight, but we need to do things that help them to get enrolled in panels, be credentials in the most expedient ways we can, and not stand in the way of provision of healthcare services. Carriers and payers use the credentialing process to determine if providers meet the requirements to participate in their panels. Maryland's credentialing statute was intended to be helpful by providing uniform timeframes and administrative mile markers across state-regulated health insurance, Medicaid managed care, and dental plans. But the statute is old now. It dates back to the 1990s, and when it was designed, when credentialing was a paper process. The providers filled out paper applications, submitted their credentialing packets by fax, which they tell me they don't do anymore, or through the mail. And then carriers had to verify the credentials through the mail from primary sources, such as out-of-state licensure boards and higher education institutions. Carriers and providers also handled any official follow-up communications through the mail. Last fall, I learned of the impact of our outdated credentialing statute on providers. I began spending time with the collaborative credentialing managers at federally qualified health centers organized by the Maryland Community Health System. I heard firsthand that credentialing managers spend much of their day trying to track down information about the status of credentialing applications, responding to duplicate inquiries for the same credentialing information, and educating a revolving door of provider representatives. Then I spoke with MedChi and some other provider associations and heard a similar narrative. The credentialing process, even now, is time-consuming, administratively burdensome, and delays providers from entering practice in their communities. We need to change the process to ensure providers can spend their resources on what's most important, and that's patient care. It seeks to modernize our credentialing law by acknowledging that the process can and should be managed electronically. This is something AI can do, and I don't think anyone would object to it. We can reduce some of the specific things that we do in the bill is that we reduce the credentialing period from a maximum of 120 days to 30 days. I am in negotiation over that, so please know that that 30 days is probably not going to stay. Ensuring payers are responsive to providers' inquiries about their credentialing applications. And we heard in a bill earlier today, sometimes the communications between the payers and providers is not as smooth as it should be. So we're looking for ways to facilitate that by establishing a dedicated email address, a voicemail box, and set some timelines around response time. We want the carriers to utilize a uniform credentialing platform as designated by the insurance commissioner. If you look at our laws, that's the person who chooses the electronic platform. Right now, most carriers already use something called the Council for Affordable Quality Health Care, or CAQH form. With this form, providers can upload a single credentialing application. Then a carrier can access the application as part of the process. Use of this platform, or such a platform, reduces redundancy for both the carriers and providers. Requiring that platform to form an ongoing work group with providers and carriers to resolve operational issues. This will help the minor operational issues from becoming major ones. And providing the insurance commissioner with the authority to leverage penalties when some of the requirements of the statute are not met. Now, I personally, I'm glad that my heart is strong, because when I saw the fiscal note on this bill, it was a pretty traumatic feeling. And I think what I see in the fiscal note is that amount of money is required in order to set up the system that would manage those penalties. Again, is an area under consideration. It also contains provisions to include the accuracy of provider directories for commercial carriers. When the providers use the CAQH form to upload an initial credentialing application, that platform continues to gather information from the providers and attest and give the providers the chance to upload new information, change information every 120 days, which could then be used by the payers. On the surface, it sounds pretty technical, but ultimately it's about access. You know, especially in our federally qualified health centers, our private medical practices, our dental offices, they're always working to recruit providers. But when they hire someone, sometimes they face delays just in getting them credentialed, and we think that can be streamlined. You know, here, we talk a lot about how we try to be forward-thinking here in Maryland. You know, our HEAD model is one example. A rural health transformation grant, is a recent addition to that. But some of the building blocks, the basic building blocks of our healthcare system, like the credentialing process, are outdated. I know that there are a number of concerns in the documents in the testimony that you have and that you will hear. Again, we are working together to see if we can find a path forward. And when we have that path, I hope that you will give it a favorable consideration, and I humbly request a favorable report. Thank you, and Robin?
Good evening, I think. Robin Elliott here on behalf of Maryland Community Health System. I'm just going to provide a little context and a little technical support for the bill. So this bill really came up this session because we know there are not resources to support our safety net providers, or at least very many additional resources. And we're facing huge challenges, and you're going to hear about those. So what can we do to allow providers to shift administrative resources into patient care? And that's how this bill came up. We did convene a group of credentialing managers. We've got one of our best here today, and really looked at what was working, what wasn't working. A lot of this comes back to using technology in the system that we'll be talking about today called CAQH. The provider uploads their application. By the way, CAQH won't accept the application until it's complete, so it's automatically complete. And then carriers can download that application, and so the provider just has to do it once. We found a lot of particular problems in dental, which is why you'll hear a lot today, and why the Maryland Dental Action Coalition has also been a great partner. So with that, I want to turn over to the panel, to the real experts at the other end of the table, and really appreciate Delegate Cullison for taking on what feels like a wonky bill, but as she said, at the heart, it's just about administrative streamlining so that providers can spend more time on patient care. Thank you.
I'm Sally Alborn. I'm the CEO of Maryland Community Health System. Good evening, Chair Bagnall, and good evening, Vice Chair Cullison. MCHS is a network. MCHS is a network of 7 federally qualified health centers who provide comprehensive primary caring at their 55 sites located throughout the state of Maryland, including the Eastern Shore and Southern Maryland. MCHS strongly supports this bill because it modernizes and streamlines an overly complex and outdated credentialing process that places a significant administrative and financial burden on providers. Precious resources that could be freed up to expand access to the growing number of uninsured patients seeking care as a result of the coverage changes under H.R. 1. The current credentialing process relies heavily on outdated modes of communication and does not take advantage of technology and online resources of information that can reduce the time to process a credentialing application, improve accuracy, and reduce redundancy. Wow, that one at 6 o'clock, and paperwork. The current process consumes thousands of hours of staff time and costs hundreds of thousands of dollars to administer and results in lost provider revenue in the end. This at a time when revenue is constrained due to patients' inability to pay even our modest sliding fee scales, significantly increasing our uncompensated care. The 7 FQHCs in the MCH network have a combined provider staff of 861 providers that need to be credentialed initially upon employment and re-credentialed every 2 to 3 years, depending on their licensure requirements. And each provider needs to be credentialed by every carrier with which the FQHC contracts. For that reason and many, many more, I respectfully request a favorable report on House Bill 1093.
Switch places.
Mm-hmm.
Actually, if you go back and you guys can come up.
Yes. Oh gosh. And now the real expert.
Good evening. My name is Tammy Osborne. I'm the credentialing specialist for the Federally Qualified Health Center Choptank Community Health System. And I'm here to share with you some of the challenges that I face every day with payer insurance enrollment. First is the lengthy timeline. Payers have 120 days to process and approve an application for providers. Second is the application process and forms. A lot of my day is consumed by submitting not only the CAQH application, but also the payers require their own version of additional forms with redundant information, and sometimes asking for these forms to be sent by email or fax, many times without confirmation that they're being received or processed. Most dental payers do not use CAQH, but require applications from that platform. Those must be submitted by mail or fax, compromising the security of the personal provider information. Dental providers must also have an ADA account to create a CAQH account, and this is accessed through their ADA login and password. Third is communication. It's difficult to reach a live, dedicated, and knowledgeable payer rep for application follow-up or questions. Timely responses are also an issue. Not all payers send written communication on progress of the application. I'd like to share some examples of the application process and how this bill could improve. There are 3 for dental. One submitted August 11th of 25, approved on 12/22/25. Another submitted 8/7/25, still waiting for approval. A third on 8/8/25, approved on 1/9/26. One for medical submitted 1/28/25, approved 4/22/25. Behavioral health submitted 9/5/25. I never received a notification, but found on the website on 1/29/26 that they were approved, but could not find the effective date. I do thank you for the opportunity to testify, and I hope this will help pass this bill.
Thank you for your testimony. Do you
Madam
want
Chair, I was going to say, can we just take questions for this panel?
Yes,
and then we'll
that's
bring
what I was
the
going to
others-
ask.
the other
All right, do we
folks
have questions for this panel? Delegate Hill.
Thank you very much, Madam Chair, and Madam Vice Chair, thank you for the bill. Just a really quick one. Why do we need to do this as opposed to, why aren't the providers just doing this automated system on their own and having a faster turnover? I mean, the credentialing that the hospitals are doing has become automated. It's online. It's really quick. Why do we need to push them to do this?
I think, you'll have the opportunity to at least ask one or two of them, but I think a lot of it has to do with, at least what I've been told, is the other parts of the process. So there is the original application, but then there's the verification, there's the background check, the verification of educational accomplishment, et cetera. So what I'm told is those are the things that take time. And I'm not sure how that differs from hospitals, but I have heard that it is different. And, perhaps we can look at how those two systems could work together.
Thank you. Thank you, Madam.
Okay, I see no other questions for this part of the panel. So we will go to Mary Backley, Howard Haft, and Dana Kaufman.
Thank you.
Good evening, Chair Bagnall, Vice Chair Cullison, and members of the committee. My name is Mary Backley, and I am the CEO of the Maryland Dental Action Coalition, a statewide network of individuals and organizations working collectively to improve the oral health of all Marylanders. I deeply appreciate the opportunity to be here today to testify in very strong support of House Bill 1093. The bill, as you've heard, streamlines the credentialing process with all types of insurers, including commercial dental insurance. The coalition strongly supports this bill because 61% of Marylanders have dental coverage through commercial insurance, and we want to take every step to ease the enrollment of dental providers into the network in an effective and timely manner to facilitate and improve access to dental care, which is the core purpose of the coalition. House Bill 1093, as you heard, will streamline the enrollment process. It will reduce the administrative burden on dental providers for credentialing, thus allowing them to redirect more resources and time to patient care. House Bill 1093 will also move dentists into the network at a much quicker pace. Current law, as Delegate Cullison referenced, allows dental insurers to take up to 120 days to complete a process for the credentialing application. The bill recognizes that applications can be processed more quickly through today's technology, thus reducing the time frame to process a complete application to possibly 30 days. This will allow dentists to move into their networks at a much quicker pace and will further expand dental care to even more Marylanders. I thank you for your time today, and the coalition respectfully asks for a favorable report. Thank you.
Madam Chair, Vice Chair Cullison, I'm Dr. Howard Haft. I'm a practicing primary care physician in Crisfield, Maryland. It's my pleasure to be here today to speak in support of House Bill 1093, and particularly in support of a bill that Delegate Cullison is putting forward at this particular time. This is, as has already been clearly stated, this is a bill that modernizes and calls for accountability in the onboarding process for new providers in the state. And this is at a critical time when we know that we're actually losing providers in the state. There's a critical growing need for health care as we see an aging population with more chronic disease, and particularly acutely in rural areas and the underserved areas across the state. So the problem, as stated here, is that we have a system now that not only doesn't facilitate that, but stands in the way of bringing on new providers or establishing new practices in places where they are needed. This is not a trivial issue. It is really a very significant issue. The statute as it currently exists has actually two parts, of 30 days that it allows the insurers to decide whether they're going to accept or not an application, and then an additional 120 days. So the statutory allowance now is 150 days. And in fact, that statutory allowance has no teeth in it. It doesn't appear to be any penalty for exceeding that. And the experience, and I'll tell you about in just a moment, is that it often goes far past that 150 days. So why is that important? If you can imagine starting a new practice from day one and having to have a facility and staff and open doors and pay for the heat and the light, and then having to wait 150 days before you ever see any cash flow, that's untenable for anyone to starting a new business. We wouldn't ask any business to do the same thing. Just want to tell you, my experience has been I started a new practice in Crisfield in March of last year, and only now beginning to get any cash flow because of this very prolonged process that's before us in terms of the 150 days plus of going on and becoming credentialed.
I do need you to wrap up your testimony.
Okay.
But I'm certain that there will probably be someone who will ask you to expound upon your experience.
Chair Bagnall, Vice Chair Cullison, members of the committee, once again, Dana Kaufman, on behalf of several different healthcare organizations. You have my written testimony, and you've heard me say it, but I'm going to say it again. Because when I read it, I found it shocking. And if we don't change this trend, Maryland is going to be in a very tough place in the future. The Maryland Healthcare Commission reported that between 2018 and 2023, Maryland lost 45.9% of our independent physician practices. And the main reason for that, besides low payment rates, is the fact, as Dr. Haft said, you can't open up a business if you can't bill for the care that you are receiving. And if you're waiting months for that credentialing process, you are still having to pay your fixed costs as you wait. And there is no business around, and we shouldn't expect it of our physician and other healthcare practitioners. So this bill is so important to make sure that, one, patients don't have to keep waiting for appointments. We hear it all the time that, patients are waiting 6 months to get an appointment. That's because we have less healthcare providers in this state now. So this is a bill that really, this and other bills really start changing that process to make it easier to begin to see patients. This is a priority bill for MedChi, and I urge your support. Thank you.
Thank you for your testimony. I'm going to open it up to questions from the members. Delegate Kaufman.
Yes, I just wanted to ask, because I got the hint from the chair, I just wanted to ask the gentleman if he wanted to briefly expand on what he was saying in terms of opening his practice in Crisfield.
Yes, certainly. Thank you very much. I was fortunate in the practice that I started that it was part of the state's Equip PC program, which was specifically to provide infrastructure costs to establish new practices in the most medically underserved areas of the state. I was also fortunate in that after serving in public health as a public servant for a decade, that I was able to go back to my roots as a primary care provider and serve underserved communities, which is where my heart is. And were it not for the fact that there was some infrastructure support to bridge the gap for for almost a year, it would be untenable, impossible for me to start, or anyone to start a new independent practice. And this does not just mean for primary care, although primary care is desperately in need in the rural areas, but it includes specialties of all kinds. They're all affected across the board by this very long and absolutely unnecessary time frame that's granted to the insurers with no accountability for having it. If you're given 150 days, they take 150 plus days to do this. I'll also point out, and this is important to note, that it's not 100% of the insurers that drag this out for 150 days or more. One insurer, a very significant insurer in the market, was able to do it in 30 days. So it is not that this is an impossibility for insurers. It is just that it's a matter of what the administrative routines are or how much intensity they put into achieving a rapid onboarding of providers. At a time when it's really critical, it's essential that we make that as short as possible to allow for new startups, new independent, or even other providers that aren't independent to be able to be credentialed promptly and brought to do the work that's necessary in the state to improve the health. So, and I also tell you, the process over the last year with 9 MCOs and a plethora of insurance companies, everyone is different. Almost all of them still require CAQH, as you heard, but it's not, they don't allow that to be the basis for the credentialing. It's CAQH plus, a dizzying array of other pieces of paper and other kinds of things that, as you've heard also, frequently get lost, misplaced, not communicated well, and add additional steps. So if we talk about waste in healthcare, this is a good place to reduce waste.
Thank you. Are there any other questions for this panel? Seeing none, thank you very much for your testimony. We do have quite a few witnesses today, so I'm going to try and be balanced. I'm going to go to a favorable with amendments, then an unfavorable, then we have another favorable. So let me go to a favorable with amendments. I have Kimberly Robinson.
Good evening, Madam Chair, members of the committee. Kimberly Robinson on behalf of Care First Blue Cross Blue Shield. Here, signed up favorable with amendments on House Bill 1093. So we appreciate very much what the sponsor, the vice chair, has put forward in this bill. There are certainly parts of the bill that are of concern, but we have had the opportunity to begin having conversation with some of the proponents of the bill to find some of those places that we can find agreement. I will highlight just a couple of facts, though, for the committee, just to give you a little perspective on this whole issue. When we talk about credentialing, it's not something that carriers just do just because. We do it for a couple of reasons. First of all, because we've got networks and we are going to use those to direct patients to a group of providers that we're encouraging them to go see. You want to make sure that those are providers you would want them to go see. So we are going to take the time to do the background check and make sure this is a trustworthy provider who does have the credentials that they say they do, does not have a horrible record of disciplinary action, et cetera, et cetera. And that is all part of the credentialing process. Beyond that, when it comes to our group-based business, again, we don't just do it because we want to. Those employers who are choosing to contract with providers often require that we have certain accreditations, and those accreditation companies require that we do credentialing in a certain way, right? So there's a lot of standards that are a part of all of this, all aimed at making sure that we are doing things in a way that are going to best serve patients. There are things in this bill that I think we can easily work on. Some of the timeframes are being reduced dramatically, and they're just not practical from a business perspective, but we are happy to be in conversation about those and how they perhaps can be adjusted. There are some other provisions that create some any willing provider in terms of how those things are being done. Those things tend to be problematic, difficult to implement, and also particularly costly. And at the end of the day, all of this cost comes back to consumers and premium. So I look forward to having the conversation with the vice chair and with the others on the bill. And that concludes my testimony. I'm happy to take any questions.
Thank you for your testimony. Are there any questions from the members for this witness? I just had a couple questions for you.
Sure.
Again, to help us be informed on this bill. Do you know how long the average background check takes? Because I know in education, they do background checks as well. I'm just wondering if they line up in terms of the credentialing.
The background check specifically, I do not, but I will certainly see if I can get an answer.
Okay, and just one more question, because
Sure.
I know that you were speaking to like the in-network, and you want to make sure that you're credentialing providers that people want to go to, and I think we all appreciate that.
Sure.
How often do you update and verify the providers that are on your in-network registry that they are still providing services, taking new patients?
So two different questions. I guess I heard the first one, when you say update, I guess I was hearing that as re-credentialing. Is that not what you meant? You just meant to see if they're taking new patients?
I mean, in terms of verifying that they're taking new patients, that they are going to be responsive to.
That's a good question. I actually don't know that. I was focused on the credentialing. That's not part of credentialing per se, so I would have to ask that question as well.
That's all right. I appreciate it. If you could just ask the question and get it back to the committee.
I'll find out what the process is for whether we proactively ask them or we expect them to report it to us to let us know when their panels are closed for new patients, but I'll find out what the answer is.
Thank you very much, and thank you for continuing to work with the bill sponsor. This concludes this panel. I have an unfavorable panel. Michael Johansson, Allison Taylor, and Matthew Celentano. You want to come to the table and give your testimony. Oh, I think Allison may still be in the other committee. Okay. We'll make sure the record reflects. Thank you.
There you go. Okay, I'll go. Madam Chair, members of the committee, still Matt Celentano, still with the League of Life and Health Insurers of Maryland. And here to advocate that we have a new drop-down menu option, which would be opposed as introduced, but favorable to the process. I think I sort of messed up that option, didn't get there. But first and foremost, we want to thank Ms. Kaufman, so the provider, some of the proponents, for already having a conversation with us around this bill. There is definitely room to have a continued conversation about the modernization of credentialing. We are committed to that process, and we want to return a product that this committee can be proud of before the end of this session. So we will be at the table and we'll continue. So opposed is introduced, favorable to discussion on House Bill 1093. Thank you.
Thank you, Madam Chair. I'm Mike Johansson on behalf of Maryland Physicians Care Managed Care Organization. A couple points. Safety net providers such as FQHCs are critically important to have in the Medicaid program generally, and every MCO wants to make sure that all of them are in their network, including, and I think as you get an FQHC in, but they change, staff, right? So you want to get all those new providers in so there's no problems. MPC itself receives over and processes 2,000 credentialing applications a year. Some of the standards that were mentioned, MCOs are now NCQA accredited, so we have to follow NCQA guidelines in order to have a proper credentialing process. That includes an independent credentialing committee made up of physicians who are volunteers. Right now, with the current timelines, they meet once a month. If the timelines get shorter, those volunteers are probably going to have to meet twice a month, which isn't necessarily a burden, but they also have 2 or 3 hours worth of work that they prep time before they come. So there's components to this process that are more than just what you would think is the corporate process. Currently, we are processing on average those applications on 34 days, which means if our credentialing committee only meets once a month, they're actually being processed very close to the time that they're reviewed by that credentialing committee and they are issued approvals. Less than 5% hit that 90-day time frame. And those are usually providers, what we say, with issues, which means they have either prior cases or some disciplinary proceeding, and it takes more time to actually make a recommendation among the committee members on how they should be either a yes or rejected. If the timeline gets too short, I think what you'll see is more providers could be rejected, which then means they aren't necessarily being approved, so it's not solving the goal of getting them in the network. They would be rejected. The last thing is for providers with issues, they actually go before the MPC Board of Directors because the board wants to ensure that they have the final say on the ones that have issues. And that board meets, once every, 6 times a year, so once every 2 months. But we're processing as many as we can, as quickly as we can, and I think the 34-day average tells you that we're doing a pretty good job with most of them.
Thank you for your testimony. And I will say, I think the drop-down menu you were looking for is information. Are there any questions for this panel? Seeing none, thank you very much.
Sure.
Seeing none, thank you for continuing to work with our sponsor. And we have one more panel of favorables. I have Stephen Dargan, Aaron Dorian, and then one virtual witness, Anita Butani. So if you want to come to the table and you can start your testimony. Oh, that's Aaron. I think you are enough. You are enough.
I'm not Stephen. I am Aaron Dorian here on behalf of the Maryland Assembly of School-Based Health Centers. MASBAC represents 90 school-based health centers across the state, providing technical assistance to existing and new school-based health centers, as well as advocating on behalf of the centers and the students they serve. So you heard a lot today, especially from the sponsor and the vice chair, and we thank you very much for introducing this bill. And we're very excited to work with both the proponents and the opponents to make sure that this happens. I just want to say that, 120-day time frame to get a provider credentialed is essentially half the school year. And so school-based health centers just cannot wait that long to get these providers into their communities, into our schools, and make sure we can serve the students that need these services the most. So we are in strong support of House Bill 1093, and I'm really glad that the League is here in supportive of the process.
Thank you for your testimony. I'm going to bring up our virtual witness, Anita Butani, if you want to go ahead and unmute and begin your testimony.
Hi, good evening. Thank you so much. My name is Anita Butani, and I'm the founder of Bright Day Pediatric Therapies. I want to pick up on some of the issues that Dr. Haft raised about new businesses. Bright Day provides behavioral therapy, occupational therapy, and speech therapy for children with autism and related conditions. And as a new business, we have run the administrative gauntlet of credentialing with 14 different regional insurers. And I've seen firsthand how duplicative red tape in the insurance industry stifles small business healthcare providers. And so I'm here in strong support of HB 1093. With autism rates of 1 in 36, demand for care is surging while supply of care continues to lag. Many Maryland children are on wait lists for years, missing critical developmental windows that can determine their long-term outcomes. But supply isn't just lagging naturally. It is being intentionally bottlenecked through the credentialing process. That's because, under the current system, insurers are financially incentivized to keep families on wait lists. Here's how it works. Insurers receive fixed monthly payments for every enrollee, whether that enrollee receives the care they need or not. And those payments are risk adjusted to the population. So when a child with autism is stuck on a wait list for care, the insurer effectively collects a windfall. They get to pocket that child's premium while providing zero services. This isn't just a delay from benign administrative neglect, it is a failure of consumer protection. Through our experience, we have seen insurers use the credentialing process to limit the supply of care. They close panels for high-need services like ABA despite wait lists, create months-long administrative delays, and hide behind ghost networks of outdated provider lists to give the illusion of network adequacy for a population while failing to meet the actual needs of the families they are being paid to serve. We need state regulations to catch up to these tactics. And I'm about to run out of time, but I want to urge a favorable report on this, and I want to share that I'm happy to answer some of the specific questions that the chair raised to the Care First rep. I do have experience with some of those issues, and I'm happy to share those data points.
Thank you very much. Thank you for your testimony. I'm going to just call for Stephen Dargan one more time. All right, he might be in another committee. And I will go ahead and open it up to the members for questions. Did anyone have questions for these witnesses? Seeing none, I just wanted to ask Ms. Butani if you had more information about some of the questions that were raised previously.
Yes. So with regard to background checks are typically, I don't know about the CGIS system that Maryland uses, but they're typically not that big of a deal. The bigger issue is the way that the way that payers are actively losing paperwork, taking forever to sign things. I have an example. We received a contract after 3 months with a payer, and I signed the contract, and they responded and said it will take 180 days to countersign this contract. So, this really gets to the point that Dr. Haft was making, which is how on earth do you run a business not knowing when you can actually serve patients? I mean, how do you accept insurance? And then with regard to the question that you had asked about updating provider directories, I can tell you that we have a new provider who joined us 2 months ago. We have contacted several insurers. She's already credentialed with these insurers to say, can you please affiliate her to our practice? They have not only not affiliated her, despite it being 60 days, despite her already being credentialed, and this is just a matter of moving her from one practice to another practice, they also haven't updated their provider directory. So this person continues to be listed as accepting new patients from her old provider, which she is certainly not. So then what you see happening is the insurance commission looks at those provider directories and says, oh, you have 250 providers that are accepting patients. You have an adequate network. And the insurers use that data point to close their panels and not accept new providers. But we know from our own experience that those provider directories are inaccurate. And that's why I really love that HB 1093 gives providers the ability to update their listings. It gives that control there so that we can make sure that we are being listed correctly.
Thank you very much for your testimony. Are there any further questions for this panel? Seeing none, thank you very much. This does conclude the bill hearing on House Bill 1093 and our bill hearings for today.